program. Astra has programs. The ABS is going to have some programs. Radiating Hope, Reyes Cancer Center has done a big brachytherapy contouring program for Africa. And we could definitely, I don't know how many were, I know she was there. So, but there are definitely ways to do this.
So the other comment I was going to make is there is a problem with connectivity. What I mean is transporting images, for example, from the CT machine to the treatment planning system is an issue. You know, a lot of these machines are not really connected via a LAN or something. Is that necessary to be able to do this? Okay. Okay. Hmm? Yes. Is it necessary?
DICOM is important. So not all centers have DICOM. So, I mean, that's what we would have to work on, right? So, right.
Well, thank you. You see, we are so unique. I know IAEA has involved one or two of you in the AfroNet before, even the BVGH that is trying to organize this thing. But you see, if we can harmonize things, unfortunately, different centers have different peculiarities. Like this DICOM through which you can transfer, its own center is not having. And what can we do so that we are all speaking the same language? Because you are involved with the AfroNet, I'm sure, and you too. The BVGH that is on weekly too. I think, and let's see how we can harmonize things and speak the same language.
So the other thing that a few of us are involved with, and actually Susan is going to be chairing, but Bonale and Ade are, and Riet from Stellenbosch are inputting into the agenda. So Jack Esther actually wants to do a brachytherapy training course focusing on image-guided brachytherapy. They have an online course called Brachyterra, and they've done the course successfully in India, Sri Lanka, and they want to develop a course for Africa, but they want us to dictate the agenda. So Susan's chairing that, and several of the folks in this room are actually inputting into the agenda. And so far, the topics that we've come up with, and maybe you want to update everybody, is one topic is on just safe implementation of 2D brachytherapy, and then the second large course would be on implementation of CT-based brachytherapy, right? So if you have ideas and issues that you want to bring up that should be on the agenda, so there's like a focused discussion on it or a focused lecture on it, that would be really helpful. So please find her and comment on that. Okay, just give me 1 minute.
So, so DICOM is going to be important. So we, and whatever we can do to help you get the DICOMs, let me know. But like I said, I do have slides. We can do that tomorrow and do the slides to kind of go over the basics. But, because I'm supposed to do this again tomorrow, but I can definitely do the basics tomorrow. But what other questions, or, because they really wanted to keep this casual, on what we can do to help? I mean, we can definitely help. I can definitely help with training. And I can definitely help with both physics training as well as physician training, because I do have a lot of physicists who are very interested in this and who are just trained as brachytherapist physicists, because that's the other big step. So before you go to 2 to 3D, your physicists have to be trained. I mean, that's even more important than you is your physicists, because they have to be able to label and put the instruments in correctly before you can even plan, right? So that's the big step. And again, A-Front has courses, and we just finished a brachytherapy course through A-Front on brachytherapy, which included physicists and physicians. She was definitely there. She asked me thousands of questions. But there are other resources that we can definitely help with. So anything else?
Thank you. She wanted me to mention the topics that have been listed for the one you're working on. Okay, so here there is patient presentation, anesthesia, choice of applicators, brachy application process, imaging, applicator reconstruction, contouring, optimization, plan approval, applicator removal and discharge. And I think we have added history of brachytherapy, then we have added safety, how to handle emergency. So presently we're just collating the topics that will be related to us, so that at least when they are coming up with the material and the lectures and the faculties, it will be targeted to us. So another thing that, like you're saying, is here we have more advanced disease. So that's why we're even talking about neoadjuvant, but the idea should have been interstitial needles, which we still don't have in the country. So at the end of our EBRT, we still have a lot of residual disease that our tandem and ovoids cannot handle. So we still need more training, because I think at the time, somebody donated some freehand interstitial needles for us. So the fear of not knowing how to go about it. Then ultrasound training will also be very, very important, because it's our therapists that will guide us. If you have a good, somebody that is very vast in ultrasound, it can also help you even when you are doing even with the 2D to the 3D, ultrasound training too. I think I should also include that, will also be very necessary. But like you said, in 3D, in fact, it's as if the physicist is more important than the physician, because they need to know it. If they know it, the work is almost half done. The rest is just for us to do the insertion. So the physicist training is quite important. Thank you.
So, and let me say something. She is absolutely correct about ultrasound. Whether you do 2D or 3D, ultrasound is so important to make sure that your tandem is in the right position. The advantage of ultrasound is you can also do it for interstitials. And we used to actually use ultrasound all the time before we had our own room with the CT for our interstitials. So they would really show us both where the needles were. You could do it abdominally and rectally. So ultrasound is, you have to do ultrasound. So, yes.
Again, if we are working as a group, Nikita, Doc, if you are working as a group, please don't look at things just from your own unique center. Look at things from the angle of all the centers. You just said one thing now. Ultrasound guidance, no doubt about that, is the ideal thing. And that was why I used to cry at that time, before you commission those machines, before you, those of you that can bear me witness, I was, get these things ready before you start. But all everybody is interested was to commission the machines, to commission the machine. How many of those centers now have ultrasound with them? But don't just take your own unique center. When you are discussing, take into consideration other centers along. Do they have this ultrasound machine, or just your own center? Because I made it known then that all of you should have your ultrasound machine. But all what everybody is interested, commission the machine, commission the machine. Now you put the machines to use. Where are the ultrasound? The minimum thing we should have with you. But not all centers.
Yes, okay. Yes, I agree. Not all centers, but centers were actually advised to procure, and we did procure. Also from the grapevine, I think IAEA is also procuring some ultrasound machines, which should be coming shortly. So, but I didn't say that.
This is off record. Just take this one to off record. When we had our IAEA training, they promised us some. That was the one myself and Dr. Ali Gome went for in Zambia. IAEA promised us applicators, tandem and tandem and ring and tandem. up to this very moment, mails and mails and mails have been sent. So I'm saying this off record to help us remind the IAEA. But really, going forward, we need interstitial needles. You are doing some good works for Zambia. Extend the good works to us, please. Also off record.
Okay, so off record, I did not get needles for Zambia because they're $1,000 for America. So just off record. There are freehand needles that I got for Zambia.
Well, thank you so much. I am taking you a little bit back. And, I think we put the cart before the horse. And that is why we run into those problems. It's not the clinicians' fault, but perhaps the policymakers that decided to do...
Hello, please, 10 more minutes for the breakout session.
You are breaking us already. So where was I? Yes, the policymakers decided to procure equipment without contacting us. And then when that happened, there are institutions that were already expecting and were waiting to support that endeavor. And there are institutions that were really not interested. And that was why a lot of the high dose actually decayed before even starting. To my mind, I think we really need to go back to the basics. And every institution must develop that template, the IAEA template on how to establish brachytherapy services for gynae patients. And that is the first thing. The second thing is that we must be able to influence when do we get our basically infrastructure from the source to the applicators and so on, before we even talked of who is going to do what. If we can't do that, then we will continuously have this issue of I have an applicator, I don't have an applicator, we can't share and so on. Even, where I practice at the National Hospital, which is supposed to be, at the seat of government, and probably we have more, we are luckier to have, listening ears very close and all that. We still have a lot of issues relating to technicalities, things that we can actually, if there is commitment, sincerity from policymakers, things that we can do. But the most important thing to me is to be able to convince policymakers that, look, whatever you are investing is something that you can get tomorrow. Because patients are paying. It's out of pocket. We have some insurance here and there, but patients are paying for these services. And those that can afford travel abroad and pay all this, $1,000 is really nothing for any institution if there is commitment. We are just simply not committed to doing these things. Let me stop here, because I can talk.
I completely agree with you. I think equipment is easy to buy. What we're lacking is the will, the commitment to it, and the right focus on training and sustained education on this, right? And this is where, I guess you all know me well enough now, I think aortic needs to really step up. We need to sort of make this a huge focus for the radiation oncology special interest group. What we would like to do, this group that we've created in Brachytera, is that we do this online course, see what the interest is, and how many people sign up, how they take up. It's completely free. And Brachytera is not funded by anybody because they actually want to stay completely vendor agnostic and don't want to take any funding. They just want to focus on education. If this works, they want to do an in-person workshop and bring in the mannequins and everything and do a proper workshop on image-guided brachytherapy. And we need to keep doing that until there's a big uptake of brachytherapy in Africa. So, and the second thing is, again, since you know me well enough now, we need to collect data. We need to collect data on our patients, the doses they're getting and the outcomes that they have, because that's the only thing that we can publish, take back to then policymakers. Even if they don't read the journals, you know what? Someone in media is going to pick up and be like, this brachytherapy is not good enough. This is the recurrence rate, and we can do better. And that's going to force, the policymakers to then further invest in this.
So because I know my friend here is actually working on her data, and she's looking at 2D versus 3D. Ghana just published their data on 2D versus 3D. So I agree. You need to collect the data now on what you have. You do need to present it. There's enough data that shows 3D is better than 2D, right? So if you show it to your policymakers and show this is what we're getting and this is what the rest of the world is getting and why, that may help. Yes.
Hi, I'm a medical oncologist. So this is my own observation from outside, sitting outside and looking in. So this looks like an implementation science issue, right? Everybody knows that this is a fact, but what is the reason why there's a failure of adoption? This is not an adoption problem. They always say that culture eats strategy for lunch. So this is a cultural issue. So we have to find out, this is my suggestion, find out what is the issue and how do we address it. If not, you just keep on educating and training and training and training. So what is the issue and how do we address it? I think that is my own looking inside.
Yeah, and I agree. And so, Dr. Grover and I are, we're here to help, and whatever we can do, because I agree. I can train you guys. If you can't do it at home, what's the point, right? So, what can we do besides aortic? How can we help y'all?
So I was going to say that before that. Even this series of lectures we are trying to put together, we're having one presently ongoing by BVGH on gynae brachytherapy and even prostate brachytherapy. And they've had one or twice in the past. But now that we have it in my center, it's actually making sense. So training, especially the theoretical part of it, is not our issue at all, to a reasonable extent. So what we need is the practical, hands-on. And then what is limiting the practical? Unlike before that, only few centers have brachy. As we speak now in Nigeria, we have like 6 or 7 centers that have the brachy machine. Getting source too will not be issue, but applicators and then physicists. So then the issue is that many
5 minutes more. 5 minutes more, all breakout sessions.
Only one or two centers or 3 centers have the capacity for image guidance. So most are like 2D. But even those that are doing image guidance and then the ones that are doing 2D, the kind of 2 more we have, we don't have interstitial needles to actually undo it. So like there are teachers, so to do tandem and ovoid is not an issue, it's just to brush up. But then the ones we are supposed to do, which is interstitial, that suits our what, we don't have that applicator at all. Like I said, IAEA promised, they're not forthcoming. So what we need is more of hands-on, more of this applicator, and then for our centers to be able to do image guidance. So we know what to do, we're just not equipped for it.
Thank you very much, Dr. Adibwig and Dr. Ibrahim. And I do agree that, like you said, culture will eat education. But I think that education also changes culture. I think that constant exposure to the right information is also important. I think that one of the reasons why high-income countries tend to have better outcomes is because they continue to learn. When you sit in a multidisciplinary team meeting every week, you learn something new every single time. And because there are multiple different experts coming together, having that conversation, your mind stays alert, stays sharp. If you go and take a brachytherapy training course once, you learn how to do it, you go home and then you start doing it and continue doing it, very soon you'll be doing the wrong thing. Because the information will change and the practice will change. And so I don't think we should sort of discount the role of education. I think it's absolutely important. I think you might be overestimating the proportion of people who have the right information. I think the correct information has not penetrated well enough for us to get to the point where we say we know what to do. Now we just need hands-on. Part of the problem is, yes, brachytherapy is very hands-on, but I think you might be overestimating how many people have the correct information. I think education, I was reviewing an abstract that we're going to present during the Best of ASCO session, and they spent 5 years in the pre-implementation phase on education and training, just to show you how deeply important it is. And even after they've implemented, they continue to train and educate. So that's not to say that we don't need interstitial needles. Absolutely we do. I don't think we should say we know what to do now. Just give us the needles. Thank you.
Sorry, ma. Please, there's an online comment for your session that I would like to take. Please, the multimedia, please help us unmute someone online. Someone online wants to make a comment. Just probably the last comment or something.
Please. Comment. I just want to say I completely agree with our medical oncology friend who eloquently put that we actually need to, it's an implementation science project, really. So if there's any junior faculty here in the room or any junior faculty you're aware of who want to sort of work on this project through aortic with some of the mentors in the room, please reach out to me. I think this needs to be done. And one of the leaders here should really be leading it with lots of support and mentorship from several of us.
So while we're waiting, I'm just, yes, no.
The online, is it ready now? The comment online, yeah. Speak. Go on and speak, please.
Is the person speaking?
Let him speak.
Can't you write it down on a chart?
Or put it, okay. Thank you. That's fine.
So
you can't hear
your mic. You know, the honest truth is that you see, we will talk here, but getting to putting somebody responsible. You see, when I was the head of department in my department, I tried to get people to subspecialize literally. Each person, each consultant to face, a particular field of radiation oncology. And that would have lessened the problems. But when you are jack of all trades, you become master of none. And that is the truth, and that is one of the key things. If we have a focal person in every cancer department that is saddled with only gynae oncology brachytherapy, for example, I can assure you that most of the things we keep saying we can't have it are doable. They are here. We can mobilize funds, we can mobilize training and so on. It's all over. But the truth of the matter is we are overwhelmed with doing too many. They don't want me to talk. That's okay. Thank you.
Oga, talk, please. Are you done, sir? Thank you very much. If you want to, he has dropped it in the chat box. Thank you very much.
Okay.
Time up for all the breakout sessions. Time up. Please, let's come back together.
Okay. Thank you so much. We'll move on to the next item on the agenda. That's going to be the presentation by Roach. Hello. Do we have one house? Hello. Are we done? 1 minute. Okay.
Machines were procured. It was a project when those machines were procured. Now the sources are due for change. Are you aware of that? All those machines. And The way you should rub mine is to ensure, look, it's cheaper. Please, listen. It's cheaper for you to change all these sources in the centers at once, and it's even good for the company. Look, I met the MD of that company at Estro meeting in Vienna. And are we thinking of that? On how to get these sources? And that is why I'm saying, please, I'm happy with what is happening now, so that you look at all things. It's not just the training, no. The applicators, your sources that you are using. Like I've said, all those 6 centers, your sources are due for change. Are you thinking that line? But so don't just think of your center. Please think of the whole centers when you are looking at things holistically.
Thank you, sir. Thank you, Professor Jinra. Thank you so much. So we move to the next on the agenda. Thank you so much. So,
we are having good interaction.
yes, I know, sir. We still have a breakout session tomorrow.
Okay.
Yes. I know. Yes, discussion can continue tomorrow. Please, we are running behind schedule, so we have to continue. So the next presentation is by Roach, and the presenter is from Tessa Sa. So you have 15 minutes to present.
Okay.
Thank you.
Good afternoon, everybody. Hello. Yes, good afternoon. And I will be taking you through the cost of illness study. This is a study that was prepared on behalf of Roche by IQVIA. It's a cost of illness study for colorectal, non-small cell lung cancer, and hepatocellular carcinoma. Over the next few minutes, I think my presentation would be less than 10 minutes. Over the next few minutes, I'll take you through the objectives of the study, the model overview, and the results. We will conclude, and then I would leave you with some additional insights from the expert interviews that were conducted. I will just skip over this slide, because I think talking about this slide here would be like preaching to the choir. So I'm going to skip over it and go straight into the meat of the matter. So the objective for this study was to evaluate the economic and humanistic burden of colorectal, non-small cell lung cancer, and hepatocellular carcinoma from the societal perspective in Nigeria. And I know at this time you may be wondering, why would Roche be carrying out a cost of illness study? So we carried out this study from the perspective of personalized healthcare. Personalized healthcare contributes to the equitable distribution of healthcare in terms of addressing needs and disparities that are faced by different patient groups. You would also agree with me that the impact is that overall it tends to reduce the cost of treating these 3 areas, or these 3 disease areas that we're talking about. So personalized healthcare helps to get the right treatment to the right patient at the right time. And the PHC vision is really to get better patient outcomes while ensuring that we're using healthcare resources more efficiently. And that, you agree with me, will contribute to reducing the cost of treatment. And so we wanted to establish that baseline for personalized healthcare. So, in terms of the model overview that was used to carry out the study, we did this from the perspective of the society, the cost of illness to the society. It was a mathematical model, and we denominated this on the Nigerian Naira. The time horizon for this study was 1 year, and the population was adult patients with CRC, HCC, and lung cancer. The key inputs that were used for this study were epidemiology data, direct medical costs, and as well as indirect costs in terms of productivity loss, travel costs, and all of that to patients. The key outputs that we were looking for were the direct annual costs in terms of medicines, interventional studies, consultations, laboratory tests, and as well as inpatient and outpatient hospital services. In terms of indirect annual costs, we were looking at productivity losses to the patients and the caregivers. We looked at the transportation costs to both patients and caregivers. And lastly, we also considered the humanistic burden in terms of disability-adjusted life years. So this is actually an executive summary of this study that I'm going to give you. For more in-depth information, you can come over to the Roche exhibition stand and we'll take you through. But what did we find? We found out that the total cost of illness for these three disease areas amounted to about 150 billion naira for the total patient population, the incident population. And we were looking at approximately 20,000 patients. In terms of the cost of illness per indication, the indication with the highest cost of illness in Nigeria came out to be colorectal cancer, with a cost of almost 87 billion naira. Now, let's look at this from the cost per patient at the patient level. At the patient level, the indication that had the highest burden on Nigerians was actually hepatocellular carcinoma at about 9 million naira to treat. This was followed by CRC, about 7 million naira, and non-small cell lung cancer at about 4 million naira. But when you look at it from the population perspective, the indication with the highest cost of illness in Nigeria was CRC at about 87 billion naira in total. Yeah, at about 87 billion to treat the incident population, followed by HCC at 57 and lung cancer at about 6 billion naira. What about the humanistic burden? In terms of humanistic burden calculated in life years lost and years lived with disability, we found that the total burden was about 156 life years lost for this population of about 19,000 patients. And the indication with the highest humanistic burdens in terms of life years lost was liver cancer, while CRC has the highest burden in terms of years lived with disability. So, in conclusion, the total annual economic burden of all three cancers is about 150 billion naira, and the highest contribution in terms of direct costs is in terms of direct costs and interventional procedures. Indirect costs also are driven by productivity losses by patients and their caregivers, and they make up 33.8% of the total cost. What are the recommendations? The recommendations are that the cost of illness has demonstrated that there is a substantial economic burden associated with these three cancers in Nigeria, and that it is essential that policymakers will prioritize the implementation of policies in terms of early screening and diagnosis to ensure that there is affordability of effective treatments. There should also be investments in these disease areas in terms of prevention and education programs to ensure that, the cost is not so much on Nigerians. So I'll leave you with this in terms of the insights. I'll not read this out, but I'll just leave it on the screen for you. Thank you for listening.
Thank you, Tesase, for your presentation. So we just take questions for him. Does anyone have any question for Tesase? Questions, please. Okay, let's put our hands together for him, please. Thank you. So the next we are going to will be the panel discussion. And the topic of the panel discussion is access to healthcare financing and universal health coverage for cancer patients in Nigeria. So the moderator for this session is going to be Dr. Amakala Shebikon. She's the president of Arcon and director of oncology at UNTH. Dr. Lashebikon, please, you are needed up here. Please, can we put our hands together for her, please? Thank you. So, maybe you take the first seat. Then the first person I'll be calling will be joining us virtually. I hope we are ready for that. So the technical team, are we ready for that? Dr. Zainab Bagudu. She's the the founder of Medicaid Foundation, and also the chairperson of First Ladies Against Cancer in Nigeria. So she'll be joining us virtually. Then following that, we'll be represented by Dr. Uche Nwoku, who is the Director of Clinical Services of NICRAT. Dr. Uche Nwoku, please can we put our hands together for him? Thank you. Then we have the Regional Coordinator of Nigeria Health Insurance Authority by the name of Dr. Uko Eberechi. Dr. Uko Eberechi. Thank you. Let's put our hands together for her. Okay. So, the aim of this panel discussion is to examine the financing gap in oncology in Nigeria, and also to highlight the progress made so far. So, Dr. Lashibikon, the floor is yours, please. Oh, sorry, before we continue.
Okay.
Please,
Thank you, Dr.
Lashibikon.
Akile. It's fine.
Sorry.
There's one more person.
Yeah, one more person. I'm so sorry about that. Yeah. So I'll be calling on Mrs. Ijoma Kane. She's the...
Kaine.
Sorry?
Ijoma Kaine.
Oh, Kaine. I'm not Igbo now. Mrs. Ijoma Kaine, permit me for saying Kane. You know, maybe I watch football too much. I know Hurricane. Yeah, so she's the president of Patient Advocacy Group, and also the president of UNTH Cancer Support Group. And also, she's a 5-year breast cancer survivor. Please, let's put our hands together for her. It's not easy. Thank you. So we can get started, please.
Okay. So good afternoon, everybody, and welcome to today's session on healthcare financing. And I think this is great that is coming after Dr. Tessa's presentation on the cost of illness study. During his presentation, I'm sure many of you, including myself, was alarmed at the disclosure that somebody who needs treatment will spend, at the very least, 7 million on treatment. We all live in Nigeria. We all know what the financial situation is. We all know what the incomes are of the average Nigerian person. So if we think about that and think about how much people earn, and how much they need to spend on cancer treatment, you'll all agree with me that this is really an important thing that we need to discuss. When we talk about equity in oncology, we are trying to ensure that people all over the world, irrespective of where they come from or where they reside, are able to, afford and access treatments for cancer. I see you nodding your head, Ijoma Kaine. I know we will get into that, your experience and some of your thoughts around this. So very quickly, this session, as has been pointed out by Dr. Ikile, seeks to examine the financing gaps in oncology in Nigerian health system. Even before we go on to talk about the challenges, we must acknowledge that we've made some inroads with the advent of the expansion of medicines on the Cancer Access Program. We know that the Ministry of Health in the last couple of years also introduced the Cancer Health Fund, which has seen patients with breast, cervix, and prostate cancer access their treatment free of charge on the CHF. Well, interestingly, from that study, I'm sure you're thinking of expanding it. With HCC gulping 7 million and CRC 6 million, they are not covered. So I'll start very quickly with our guest from National Health Insurance Agency, Dr. Eberechukwu Uko. And I'll ask you the first question. What are the most pressing challenges in financing cancer treatment and research in Nigeria? Like I mentioned before, we know that there have been inroads with CAP, CHF, and NHIA. You've recently expanded your portfolio to include cancer medicines. But tell us, what are the challenges NHIA has experienced in trying to roll out funding for cancer care? Please, can we get an extra mic? 2 or 3, please. IT, can we get an extra microphone, please?
Good afternoon, everybody. Thank you for having us here. Thank you, Dr. Lashibikon, for that question. So for the NHIA, one of our biggest challenge really has been the fact that the uptake of health insurance has been on the low, right from the inception of the health insurance schemes and programs that we have been implementing. We are still sort of struggling to have as many Nigerians covered as possible. And that has really been a challenge for us because we need to grow the pool to be able to provide access for all this care. And like you've just heard, cancer care is expensive. So we need a very robust pool to be able to cater to those needs. With the signing into the new law, of the new act, we now have the mandate to cover all Nigerians, and that also means that all cancer patients in Nigeria should have access to care. So one of those challenges is how to get everybody on board. And another thing really is the fact that the treatment costs are high. Sometimes we have made some inroads, improved or increased, expanded cover, only to find that maybe the funds that we had allocated for that were not enough. As of the time that we started covering for cancer care, was about 2 million per case if we were to cover wholly, and now we're hearing it's 7 million. So cost of treatment is high and it will always rise. So we need to be also able to find mechanisms to control the costs of care as much as possible.
Two questions. You rightly touched on the fact that the pool is low. Do you have definite figures of the percentage of the Nigerian population that is enrolled? And even as you think about that, why, during the presentation yesterday, somebody mentioned about accessing NHIA, and that when they did the survey, quite a number of patients said they were not aware that NHIA services were, available, and number 2, that they would cover cancer care. So what do you think the NHIA can do to improve awareness and then, of course, uptake of these services? That's number 1. Then number 2, you did say, that the cost of care, is rising. You need to find a way of capping it or at least managing the expenses. With the fluctuations in the dollar rates, that has taken everything up. So perhaps, are you thinking that maybe policies would be able to peg down the cost so that it's stable? Or again, the question would be that do you think there's a way the NHIA can expand the per person allocation so that we're almost always able to meet that demand, of costing to a certain extent?
Okay, thank you. So in recent times, we have developed other programs. There's something we call the gift ship, and then we also have the health insurance under one roof. And what we've done with that is to actually seek the collaboration of the state health insurance agencies to enroll persons in the states into health insurance. And with that, we've been able to expand the cover a little bit more than it was before. I don't have the statistics here, but I can tell you that in the past 2-3 years, we have actually increased the number of persons enrolled under the Health Insurance Authority. Now, for awareness has actually been a bane of contention for us. We have partnered with a lot of companies and partners to increase awareness at the grassroots level. In fact, we're also working with Roche and another company to take the message out to all Nigerians in the modes that they can understand it. So we're looking at how we can get many more people enrolled, and that's what the shares are also doing for us. They're talking to their people at the local government level and making them understand that health insurance is something that is good for them. You know, you also have to get people to understand for them to be willing to pay for these services, because people in Nigeria, the tendency is for us to think that, why should I contribute towards health insurance? When I get sick, I go to the hospital. But it very often isn't like that. Once one is sick, it's always a catastrophic event for the family. So we're trying to let people understand that enrolling into health insurance in good time is a way of avoiding those catastrophic burdens. And so we're partnering with as many organizations as we can to get that message across. And that will hopefully increase uptake in the near future. Another thing we're leaning on now is a new law, as it mandates everybody to register. So the possibility that you would need your health insurance before you can maybe get your international passport is there. And that's how we're going to try to increase the uptake. Health insurance is compulsory, so we need to put in strategies that will ensure and enforce that people get enrolled into health insurance. For the costs of care, I don't really know if we can force manufacturers to reduce the cost. But what we can do is negotiate with them and make them see the need to bring in these products to help our people. There's a need for us to see cancer as a big picture. It's not just about me or my family or people I know, but everybody is affected by the cost of cancer. But one cancer patient in one community can actually drive the resources of that community, especially if we are all contributing towards that care. So what we have put in place at NHIA is there is an initiative we call the Medicine Supply Initiative. And what we're trying to do with that initiative is see how we can leverage on collaboration to reduce the cost, to negotiate with manufacturers about the costs of medicines, and eventually also the costs of equipment that can be used in the oncology space. So that's the strategy we are hoping to leverage on. Another thing we're hoping to do is partner with private organizations that are willing to come into the space and provide some care. At least if we are able to find a number of partners, we can also improve and expand the scope of coverage in the health insurance industry.
Okay, thank you so much. I think that one thing is clear, is that NHIA is being proactive and looking at engagements at multiple levels, at the local level, engaging with the community, which I think is critical to the success of the uptake of this package, even though it has been mandated by law. Having the national, mandate playing out also would be interesting to see, especially as you say, is linked to getting the passports. And with this JAPA era, that might just work. Okay, but I think that, with Ijoma Kaine sitting close behind you, perhaps you might want to engage patient support groups as well, because they can actually tell the powerful story of how the costs can be crippling and how the financial toxicity that usually comes from cancer care would really send most families into abyss. So perhaps maybe you might also want to consider talking to them as well, because personal stories do have a way of, asking people, making people to change their stance. So I'll go very quickly to you, Dr. Uche, representative from NICRAT. So NICRAT, as we all know, is the new baby in the oncology sector. Quite a number of activities that are being run or going to be coordinated by NICRAT have actually been in existence under the cancer control decks at the Federal Ministry of Health. So the question now is, what is the difference we hope to see with NICRAT really taking the lead on cancer care and cancer treatment in Nigeria? You have an insight because you've been there, you know what the problems are, with the new acts and the enabling environments that NICRAT, we hope NICRAT would have, what do Nigerians hope to see as the difference?
Thank you, Madam President and everyone. Before I go on, just want to bring greetings from the pioneer DG of NICRAT, under whose mandate I sit here. So whatever I say is what he has directed that we'll talk about. And then NICRAT is just about 8 months old. However, our actions is much more than 8 months. Having said that, most of the things that are being done in the cancer space, especially with improving access to cancer care, and especially in terms of financing, is what the government has been doing for a while. And if you ask me what can be done differently, it's very simple. It will be different now because there are a lot of bureaucracies in government sector. There are a lot of financial regulatory activities that must be followed, irrespective of whether cancer is malignant and does not respect time or respect anybody, which is the case. Okay, so a number of times, one government set out money to do anything, you must follow the due process of getting and spending that money. And this is my experience, having worked in the cancer space for over a decade now, and it's been a nightmare, okay? Trying to convince government to bring money, which they will graciously put in the budget, but to now get money from that same budget and spend it, you must follow the relevant due process, or else the graft agencies will come after you. So in the last couple of years, we've been able to try to manage the Cancer Health Fund. We also manage the Cancer Access Partnership Program. These are flagship programs that have made access to cancer care in the country a little better. But the experience hasn't been too good because of bureaucracies. A number of people will sit down and condemn those who have managed that fund, saying that patients are dying, money is not being released. But the point is that there's a way you do it, even when you do not benefit from it, graft agencies will come after you. So what we tend to do differently is because now that NICRAT has come to stay and everybody has agreed, I shall be here on Monday, but with the DG, we were in the ministry for morning, we left the Ministry of Health around 7 p.m. from morning. And what we were discussing with the top echelon of the ministry was to ensure that CHF is moved from the ministry to NICRAT. That has been agreed, that has been concluded, and it's going to move. A number of other activities that have been in the ministry was to move. So the difference now is when it will take a round of file moving from my desk then in the ministry and get to about 4 other desks before you get approval. And that approval comes, it goes through the same process to come back. And those approvals will happen when the boss is on seats. So whether they're in America, like they're in Onga now, if they spend 2 weeks in Onga, that file will spend that 2 weeks on that person's table before it comes back. Cancer will not wait for that person who is in Onga to come back before it spreads. Okay? So right now with NICRAT, we just have 1 approval away. So that means within a day or less, you can get approval to do what you have to do. So it becomes a bit faster. Then because now that NICRAT has a mandate to provide national leadership, okay, so most of the things that would have happened with various tables will just happen within few minutes or few hours or thereabouts. So we hope to leverage on that mandate to do things and get them right this time around. We have the mandate by law to seek for funding from anywhere, including National Assembly, to provide for treatments and provide for research. So we're hoping that if we're able to implement our mandate by law, we should be able to make financing easier for cancer care in Nigeria, and then hopefully things will get better. So we are optimistic to see things change, and we're glad to announce that multi-stakeholders are willing to partner, both in country and internationally. There are a lot of institutions abroad who are just waiting for us to say this is what we need. They've said that to us, and then by October, ICW, we're going to launch our national cancer control plan. We're also going to launch the national research agenda for the country. So all those activities, once they're launched in October, we're able to use the document to seek for funding and expand. NHIA here, we also have a series of engagements with them to partner, because by law, every Nigerian should be on health insurance. And cancer is not different from other health services that should be under NHIA. So we're already in talk with them. We are drafting a document right now together to be able to harmonize all the activities they are doing, so we don't want to fragment efforts. So NHIA, NECRAT is sitting together to ensure that every patient who is also enrolled in health insurance will also leverage on the financing coming from NECRAT to ensure that we maximize the impact that's going to make. So it's a collaborative thing, and we are hoping that it can only get better. Thank you.
Right, thank you. I'm sure that is cheering news to note that the bureaucracy will stop. Because for many of us here who have been involved in, enrolling patients on the CHF and having them, their wallets credited, and then having them being able to access the fund, I think the greatest nightmare is that long wait, which is unpredictable, from a few weeks to a month to 2 or 3. So if NICRATs, that's why I think that it's great that there's continuity and institutional memory with you moving, and indeed the rest of the, that's the information from the CHF being handled at Ministry of Health to NICRAT, because you have already seen what the challenges have been. So with that one-stop shop, of course, as you were talking, I was like, oh, this is great news, that it's just one stop away, and then approvals will come faster. With approvals coming faster, there'll be more engagements, more funds will be released, more funds will be required. So my next question would have been, how do you intend to sustain it? But you said that NICRAT has mandate to secure funds from everywhere, and you're already looking at partnership from NHIA, perhaps maybe private sector involvement as well. Another thing that could help, I don't know, I'm sure NICRAT, being a research and treatment institute, would also be looking at the role of clinical trials, because with that, we have our patients who would, be able to access newer molecule treatments, targeted treatments, and for free. And then it's also supposed to at least bring down the cost. So I know NICRAT is looking at it. This is where perhaps the research community would need to be engaged to show them the pathway that's at least to direct the path where they should be looking at. So perhaps you might want to elaborate a little bit on that.
Yeah, thank you. So clinical trial is an area of focus for NICRAT, and not just clinical trials, the entire gamut of research that should be done as far as oncology is concerned is being looked at. Like I said, we've developed a draft national research agenda. That research agenda is going to cut across the entire pillar of cancer care, including prevention, diagnosis, treatment, governance, and everything, okay? So that agenda, clinical trial is one of the critical areas in treatment, okay? Because without it, I tell people that if all the drugs that are being advertised there, none of them was tested in Nigeria, and I bet any of them to come and say it otherwise. So if they are not tested in Nigeria, how are we sure that our own genetic makeup is also the same thing that I want to address with these medicines? So we want to insist that most of the drugs used in Nigeria should also be tested in Nigeria. Okay, so, and it's one of the key critical areas NICRAT is looking at. It's going to be an entire program of its own for the country. So we're going to explore that very well. And most of the pharma industry players are also, they are aware, and they are coming forward to see what we can do together. On the CAP program, right now, there's a clinical trial that's going to be done in National Hospital on one of the targeted immunotherapy. So it's going to be done in National Hospital, and we're hoping that we're going to support it. We are hoping that NICRAT will now play that leadership role in coordinating all the research programs in the country and all the clinical trials that will happen in the country, so that whatever is done should reflect into practice. One of the gaps is that we have many competent researchers, competent clinicians in the country, but they are doing things in silos. Most of the things, the outcomes of their research end up in their laptops. So it does not, is not part of what the country looks at in planning, in national planning, which is very bad, which is not good. So we're looking at coordinating what everybody is doing. So whatever is the outcome of your trial or research, should be documented at a national level and should also influence policy. If it cannot influence policy, then you wasted your time. So that is what we want to ensure, that everybody is brought on board so that whatever outcome you have, let's make it influence what happens next in the country.
Okay, thank you so much. One more question, sorry, before I leave you, because you said some things that are, how, this is a lot of talk, a lot of plans. Do you have an implementation strategy? Then, how do you intend to monitor? What are your processes for data analytics that will often guide you, checkmate you, and ensure that these plans are working or need to be tweaked or adapted to be able to meet your goals?
Yeah, thank you so much. One of the key strengths of NECRAT and of some of us who are also in the space is that we like to build systems. Okay, so I am a system person, and whatever we do not have planned for will just be an ad hoc thing. So whatever we have said now is what we have documented and have developed a framework for its implementation and monitoring. Okay, so the national research agenda I talked about is also has a link with the National Strategic Cancer Control Plan 2023 to 2027. That plan has its objectives, has goals, has activities that must be done within this period, and has an MIA framework also outlined and what should be done to track each and every activity we're doing. So that means per year, we're going to track whatever we have said we're going to do to be sure they are done the way we said they are going to be done. And as we're tracking them, we're reviewing the processes to ensure that is implemented as documented. And at the end of the period, we also review it and be sure whether the kind of impact we're expecting is what we are getting. So it's not something we want to do as an ad hoc thing. It's something that we want to institutionalize, which is also the other challenge the cancer space has had in Nigeria in the past. Everybody just does things, and whatever is done, whoever comes next doesn't know what the other person did. We want to avoid that. So if we have, that is I don't want to talk about, but if we have an institutionalized framework, even if future is not there tomorrow, whoever comes there should be able to follow up and then sustain what was done. So if at the end of Dr. Aliyu Malami's tenure as DG, we want to leave a legacy where whoever comes after should be able to track what happened from the beginning to the end. So that way, you have an institutional thing. Maybe what I don't want to talk about is the fact that Nigeria had a national plan to expand radiotherapy and nuclear medicine activity in the country. That plan started since 2008, but was stopped with change in government. Okay, and that is why you see different hospitals start something and not concluded, and others springing up. But we want to start something that you should be able to track whatever will start now, to be difficult for anybody to come and just drop it and start something differently. So we want to institutionalize activities that will help budgeting. So even if in the next 5 years, the plan already has a budget for the next 5 years. So we don't know how much will require in 5 years' time to do certain kind of activity now. So we plan towards that. Okay, so that way you are sure that you are not just doing things in an ad hoc manner, but a streamlined approach to addressing cancer care in Nigeria.
Okay, thank you very much. So we have well laid out plans for tackling the problems, and also a strategic long-term plan to be able to move things forward. Ijoma, are you happy with what you've heard today, both from the two government agencies?
Good afternoon, everyone. Thank you very much, Dr. Lash and Arcon, for this opportunity for the patient community to actually participate in this conference. It's very commendable, and we appreciate Arcon for having us. I represent the patients in Nigeria, having been a 5-year survivor of breast cancer, and treated in Oka and Enugu. I also want to commend the federal government. The last administration actually did a lot with helping cancer patients by creating more radiotherapy centers. It's not enough, but there's room for a lot of improvement. But yes, we commend them greatly for looking into cancer care. and also the Federal Ministry of Health. We are also appreciative for all the initiatives that they also reeled out. And going to the bodies that have come forth, the NHIA, the NCAP, and the CHF, that's the Cancer Health Fund. I'll start with the NHIA. The NHIA, yes, they've been doing well, but of course, I don't think a good percentage of Nigerians are registered under this scheme. Why? We are living a lot of Nigerians are living way below the minimum wage. Okay, so how many people really have health insurance? You know, how many people? There are just very few. Fine, it's working, because earlier this year I was surprised. I didn't know that the NHIA was actually doing all this until I saw someone. I went to have my PET scan early this year at Mikio, and a lady was there, and she was saying she didn't spend a dime. You know, I was surprised that even the NHIA could cover her PET scan. She didn't pay. We all paid, but she didn't pay. She didn't pay for radiotherapy. She didn't pay for, I mean, it was interesting. But her husband is a banker. How many Nigerians have that access? You understand? You know, and the main people going through these things are living, trust me, they are living way below the levels, you know. So how do you people intend to incorporate the market women who come down with cancer? You know, I'm sure you understand what I'm trying to say. So it's good so far, but it's not very sick. And then the awareness is not even there. You know, there's lack of awareness. Many people do not even know that these schemes exist, especially the Cancer Health Fund. Then I'll go to the NCAP. The NCAP is the association that gives us the opportunity to buy our medications at 50% cost, okay, which is fine, and they make drugs readily available also for patients. It's very good. It's a very good initiative. It's fine, but let me leave the NCAP and go to the Cancer Health Fund. That's where my interest is, because that's the one that has come down to the hospitals, especially the 6 geopolitical zones. So, but then they have a lot of hitches with the CHF, spanning from the waiting time, which they really, really complained about, you know, that you have to wait, patients get to wait up to 3 months before they can actually get their approval. So we'll plead and ask that these systems, you mentioned something like that, that it's being worked on, and yeah, but let the waiting time for patients please be reduced. Then again, let's also look into creating more cancer centers where these services can be accessed. For example, you give someone has to come from, let's say, Benue State, because, so we have Benue, we could have Abia, we have Imo, everybody has to come down to Enugu, okay, to access that care, because this is where it will be signed, this is where it will be approved, and this is where you're going to get treatment. So if we can look into increasing the centers, you know, spreading out a little bit more, that would be very nice. Then again, the funds, I don't know, the funds don't even cover end to end. When you give a patient 1 million to treat cancer, it's like, nothing, I don't know. It's a good step, we're starting, but please, a lot more needs to be done, because it doesn't cover. It doesn't cover in the sense that your basic surgery, the mastectomy, especially for breast cancer, is, the cost is about approximately 4 to 500,000, okay, for the surgery. Then you go into chemotherapy. Chemotherapy could take you another, if it has to be cheap, then it might take you at about another 600,000 or more. Then you now go into radiotherapy, which is about 800,000. Okay, when you add up these things, apart from that, there are a lot of scans. And then I also got to understand also that that fund does not even cover for stuff like immunohistochemistry. I mean, what are the doctors going to be treating if patients cannot have their immunohistochemistry done for free? What are they actually treating, you know? Then I want to plead that if it's possible, a percentage of these funds should also be given to the patients. Yes, because sometimes, even if it's 30% and then 70% to the hospital, so that sometimes when you have patients who go into the pharmacies in the hospital to take their drugs, and those drugs are not available, they have to buy out of pocket. They have to go outside to go and look for the drugs, and they still do not have funds within, you know, their own reach to actually buy these medications. So if it can also be looked at, just to give them a little, just to give us a little percentage, you understand, to actually hold, so that we can run some other tests and buy some drugs, run some scans that maybe the hospital is not able to provide at the time. So I'll commend you guys, but I want us to do more for the patients. I want us to do more. Then please, one more thing. The theme of this thing is talking about equity in oncology. Now, the Cancer Health Fund attends to just breast, cervical, and prostate. What happens to the children? Who is speaking for the children? There's child cancer. What's happening to them? Are they not part of this? Are we discriminating? Then what happens to those with pancreatic, colon, colorectal? What happens to all of them? So we'll need to do a lot more. Okay. Let's not discriminate at this point, please. Thank you very much.
Thank you so much, Ijeoma. A bucket full of requests, and I'm sure if we leave Ijeoma, she's very passionate. That is why it's always important to have a patient's voice in any discussions that regards cancer. So in summary, you've talked about a few things for the NHIA, basically to increase awareness, which I think they've marshaled out some plans. Some of your concerns, I saw she was taking notes, so I'm sure, you know, they will also look into it to ensure that they improve the uptake of these services across board. Then most of your questions fall within the bulk of NICRAT, so I'm going to let him respond. But one thing I would just like to mention that, you know, he tries to balance out, because I know that you talked about expanding the portfolio for CHF. That's number one. You also mentioned the need for expansion of centers, availability of centers. And I think that even as we think about that, you know, and try to reduce geographic disparities, we really must look at that based on the critical workforce that is already available in country that will be able to manage that as well. Then, because I will just give Dr. Uche maybe like 2 minutes to respond, because I want the idea with this session really is to be able to have a pool of ideas of what to do, you know, so that the conversation doesn't just end here. We had actually hoped to have somebody from one of the private banks, that's the banks, to really talk about some healthcare financing solutions that they have. Because even as the patients are you know, agitating for better care, I know that the private sector engagement also, some private sectors in the firms are also looking into, you know, to getting into the oncology space. But they are having a lot of challenges. I can speak for certain about the PPP that we run in UNTH. With these new policy reforms, I mean, it has almost eroded the investments that he's made. And so we wanted somebody from the banking industry to try to explain to us really, you know, what financial solutions they have and what some of the implications of policy have on investments that investors make into the oncology space. Unfortunately, he canceled at the last minute, so we couldn't get somebody else. So, Dr. Uche, in 2 minutes, please respond, and then we'll open it up to members of the audience for one or two questions and perhaps, contributions that the NHIA and NICRAT will think about to improve access to care and healthcare financing in Nigeria. 2 minutes, Dr. Uche.
Thank you. Actually, in 1 minute, I just want to say that, Ijoma, you see, the thing with planning is that you look at what we do, we represent the public health aspects of oncology. So as a country, we look at what is the cancer burden in Nigeria and where do you want to channel your fund. The fund is limited, it's not infinite, it's finite. So, and you want to see which makes maximum impact. Breast, prostate, cervical cancer in Nigeria account for over 50% of Nigeria cancer burden. So that means if we're able to address that, we have solved Nigeria cancer problem by half. So if you want to take the limited money and give to all cancers, it will not make impacts. Yet you may have assisted 1 or 2 persons, but the impact will not be visible. So that is where we started. And that's why those 3 are the ones that were targeted. That doesn't mean that it can be expanded. So now in NICRAT, we are not looking at the cancer control plan in the Ministry of Health was targeting 5 top cancers, but in NICRAT, we're looking at every cancer. Okay, so because that 1% in the population might be 100% to the affected. So we don't have to ignore that 100% to the affected because it's 1% in the population. We want to target all. So what we intend to do is to change that budget narration because until it is changed, we can't change that. The budget narration rate those 3 cancers. If you change it without changing it at the National Assembly, it becomes what we call environment without approval. Then you go to jail just for doing what is good. So that is the problem. Now, in terms of expanding access to cancer services, is also the same issue. The truth is, among all the centers managing cancer in Nigeria, which one is comprehensive? Which one has all the things required to manage cancer in Nigeria? Which one can you say you go there and everything is there? None. Because of limited resources. So it will be difficult to say you are going to put in every center, but what we need to do is to strengthen the existing ones and then expand. That NICRAT has already put in plan to ensure that every year at least some centers are upgraded and also established over a period of time. So with time, we're going to be sure that every state should have comprehensive cancer care services. That's what NICRAT is set out to as far as treatment is concerned. So it's something that we're going to work on. It's not, it wasn't as if we didn't take note of all those things, but we need to work on it based on the public aspects of what we do. Thank you so much. So some of the things you raised is what we can discuss at the end of the meeting.
Thank you so much.
Okay.
So we take questions from the audience now.
Yes, thank you.
Thank you so much. So the first person will be Dr. Igbinuba.
1, 2. Okay, go ahead.
Thank you very much. I wanted to make some comments based on Ijoma's submission. So thank you, Ijoma, for acknowledging the NHIA's contribution to cancer care. I feel that there's no better place to create the awareness than right here and right now. So I'm going to speak about a few things that in the package of care that we deliver, we actually cover most of the components of cancer oncology care. So we give access to diagnostics, as you have already experienced, and then there's access to chemotherapeutics as well, surgeries, and even radiotherapy. So all these are covered under NHIA, especially if you're registered with one of the programs. So that's the modality that we are using to try and cover as many types of cancer as possible. There really aren't any
Thank you
restrictions.
so much. Our time is fast spent.
Yes, there really aren't any restrictions, but we are able to meet up with the demands from the field. What I want you to also understand is that we are doing a lot for innovative financing to increase the scope in the cancer care. And that's why we're partnering with NICRAT. And hopefully in the near future, we're also going to be putting in more funding for screening to ensure that we are able to detect these cancers on time. And then that will also limit the burden that we have on the society at large.
I'm sorry, I will have to stop you, please. Thank you. So, Dr. Igbinuba.
Thank you very much for these beautiful presentations from members up there. Mine is a little bit, it's a suggestion to NICRAT suggestion or a different way to look at issues. Now you have research and treatment under your care. All right? We've dealt extensively with the research in this gathering. But the treatment aspect of it, in Nigeria today, there are cancers that we know, like cancer of the breast, prostate, and cervix. These are core cancers that exist in Nigeria. It's a surprise that in the whole of the country, there is no single center that can do a robotic surgery for a major disease. Tell me one if you know. I'm not aware of it. And NICRA should see to this, so that people don't start running. You are talking about early diagnosis of CA prostate and then surgery to make sure that it's a curative disease. Now you look at the whole country, no single center with robotic surgery. Not one. So NICRA should make sure they talk to the government over this and that they can at least just set up one so that Nigerians can have access to this. Thank you very much.
Okay, I think we'll take all the questions
we'll take all
together.
The questions,
yes.
Respond to. Professor Lasinde,
okay.
You have a mic.
Thank you for this session. From yesterday, look at the theme of our program, equity. And our keynote speaker dealt extensively on that. Madam Ijeoma, or NHIA. Today, even under your CAP program, only few hospitals are underneath. I can speak from a state where I'm operating. There are about 3 tertiary health institutions where cancers are being managed in that state, and only ABU teaching hospital. If you go to National Eye Center, it's not covered. And you talk of pediatric cancer, where they have a lot of retinoblastomas and others. If you go to National Ear Care Centers, where they have huge head and neck cancers, they are not under the CAP program. Now, the issue is, now that NICRAT are coming, I'm happy to hear from my friend that you are covering all cancers now. It's one thing to bring out a policy, another thing is the implementation. What are you doing presently to ensure that these drugs that can be purchased at 50% are available in all these hospitals?
Thank you, sir.
Okay.
So, Professor Adenukweku.
Thank you very much. Beautiful session. And I want to appreciate all the speakers. You've spoken very well in support of access to cancer, treatment of cancer. And I'm also happy that the CHF is now going to NICRAT. So let me quickly drop this with you. And I'm happy you said you are going to fine-tune it. So please work on it so that uptake can be, within a very short time. And then patient transfer. For now, like you rightly observed, not every center has everything. So patient transfer, please make sure you collaborate with all the treatment centers so that the cost, the price of treatment will be uniform. I'm saying this because we have challenges in Ibadan, UCH, so we need to transfer patients to National Hospital because some of them are in Abuja. And Abuja is saying the amount that you want to pay for radiotherapy is too low. And so they kept some of my patients waiting. They could not attend to them on time because you are going to give them 300,000 naira for curative. And they charge over $1 million. So you need to collaborate with all these centers, and we agree on that amount. When you are coming to CHF, treatment shall be 300,000. So please collaborate with all of them, have uniform pricing for every center, and lastly, please also make sure there is vote for research and for other things, and let the centers, the researchers know about this. Thank you.
Thank you, sir. So, kindly introduce yourself again, please.
Thank you very much. I'm Dr. Shehu Umar. My questions are to the NICRAT and the NHI of presenters. To the NICRAT, I would just like to advise that the research should be focused on what are the outcomes of our cancer patients across the country, so that we can be able to know maybe over a period of time, are we really making progress with the machines we are having? Is there value for money and all that? So if there's a way you can collate data across all the treatment centers, so that I can be able to know the patients that are accessing care, what are their outcomes generally, like a figure for the country, I think it will be a good thing. It's only the NICRAT that can be able to give us that setting. To the NHI, some of the services you are actually telling us about, I want to just tell you that some of your DEX officers in the institutions are not really aware of this, and sometimes we have difficulty in trying to put these things into practice. So please, if you can create more awareness and training for your officers, so that even if we, the oncologists, are not aware, they can actually be able to reach out to us, not us trying to tell them something that is supposed to be from them. Thank you.
Thank you. Dr. Bello. So after Dr. Bello, we'll take one more question. Dr. Morris, and that will be all.
Thank you so much for this very important topic, and I will dwell specifically on it, which is access to healthcare financing, universal health coverage for all cancer patients. I know that people are bombarding NICRAT, and I want to believe that NICRAT cannot do it alone. And the mandate of NICRAT, believe me, is being overstretched. I know that the National Cancer Control Program desk is literally now embedded in NICRAT. And I think by so doing, you are really absorbing some of the functions of NCCP. Perhaps they have a budget line and all that. If you can look into that so that the budget line remains for NCCP. Having said this, I want to talk about financing. Government cannot do it alone. NICRAT must make one of their key pillars to be able to access funding for cancer patients across the world, across the globe. You must reach out to be able to develop your own agenda and get your own financing. Government will not do it alone. Nowhere in the world is cancer being funded only by government. If you go to the United States, most of the cancer centers are being funded by NGOs, by foundations. I wonder why NICRA should not develop policies that will encourage private sector to provide care, to also provide insurance for cancer patients. Because the insurance that NHIA is covering is so minimal. At the last count, the coverage is about 2%, because it was covering only federal government staff, and some states have their own insurance and so on. So it's too small for you to be talking about universal health coverage for cancer patients. So we must develop innovative ways of financing, and we are not doing it yet. We have to self-critique and tell ourselves the truth. The truth is that it is too little, and we have to start running. That is the truth. Thank you.
So, Dr. Morris. Then after Dr. Morris, we'll take Dr. Salako, and that'll be all.
Okay.
Salako.
Well, thank you very much for a very engaging discussion. My question is to the NHIA person. I just wanted clarification concerning NHIA, the relationship with the HMOs. Because in my center, for instance, my patients are finding it difficult to access cytotoxics on NHIA right now. And I've approached the hospital management. They actually said that they are not getting funds from these HMOs. after they go ahead to purchase this medication for the patient. So a lot of my patients cannot access medication on NHI in Jute right now.
Thank you, Dr. Morris.
Yes.
Thank you. Dr. Salako, and that'll be all.
Thank you very much. My name is Dr. Bolaji Latif Salako, FMC Abeokuta. I want to appreciate the speakers for their contribution. My question is that I noticed that the speakers, they are using two words interchangeably. Some are using healthcare financing, while others are using healthcare funding. I want to know, are the two words, are they the same or they are different? If they are different, can you please just give us an insight on it? Thank you.
Thank you. Please make your responses very brief. Thank you.
Okay, so we would like to get the responses from our panelists. Just as you are speaking, Dr. Uche, because I think quite a number of the questions were directed at you. And as a follow-up to Dr. Bello's question, alternative means of, encouraging healthcare financing and looking for other partners. Lagos State has developed the Lashma healthcare financing, where they make available the sum of 5 million, a paltry sum, but definitely, somewhere to start with. Is NICRAT looking at engaging other state governments to take ownership of their citizens in cancer care?
Okay, thank you so much. A number of the things said here are comments or an advice to NICRAT, which I have taken note of, so I don't waste a lot of time responding to them. So, but just to say that the comment from Dr. Ibinoba is noted. NICRAT, we set up and support setting up of reference centers of excellence to manage all the cases that have not been managed presently by various centers. So we'll look into that. The comment from Professor Olasende, we understand that some of the hospitals do not have CAP yet, but we have an approval to expand to all centers, which we are doing. But there are a lot of challenges which we are already addressing right now, and we are going to expand to all centers. However, we do not impose this on hospitals because we understand some of the politics in that area. So, but we approach hospitals and want their access because they need to take ownership of the program. That is why some of them don't have, some have. But we're going to address that as we go along. Professor yes, so that's not said. We're already rejigging. In fact, by October, we're going to also review the steering committee for CHF, and we're going to take notes and address it as they arise. Dr. Bello's comments, that's fine. So we can't do without collaboration. State governments and all the stakeholders. There's no way we can do it without collaboration. So we are looking at all of that, and we're going to. We have a department in NICRAT called resource mobilization. That's what they do, and we are going to make sure that all the resources needed for treatment, for research, is provided, and that way we're sure that whatever needs to be done has to be done. Thank you so much.
Thank you so much. So I believe
Doctor, excuse me. Okay. I think there's a question for you. Do you want to briefly respond while we wrap up?
Okay, thank you. We've also taken note of the comments about creating awareness. The question I took down was that of the relationship between NHI and HMOs with regards providing access to cancer treatment for youth. I think that if you have any problems with receiving codes, because I think what you're talking about is authorization codes for care, and that you could channel that to us through the state office. We actually have rapid response teams that will come out to youth and help to sort out the issue. So that's my response to that. Thank you.
Okay, thank you so much. Dr. Amaka, maybe you can just wrap up with that.
Thank you so much. I think our timekeeper deserves a round of applause.
Thank you so much.
Okay, so as I round up, thank you to all the panelists. Thank you to Ijoma for really bringing your concerns to the table for the government agencies to understand, and begin to think about solutions to go around it. But one thing I must say that is clear from this panel discussion is the fact that awareness about NHIA and the products they offer is low. And I think that, as she has enumerated and as what many of us have re-echoed across the room, engagement at all levels is critical. We cannot leave it to the government to engage at only the national level, but I do believe that all of us, as we go away from here, should talk to our NHIA desk officers, make sure they are up to date with the services that NHIA is providing, so that we also should be part of that change. We also should be part of increasing the uptake of NHIA services, because unless they have that we know that our patients won't be able to continue their medications, and that ruins all our hard work and the treatment outcomes that we hope to see. We also want to thank NICRAT for all the suggestions and the plans that they have, in strengthening access to care and making provisions for financial to reduce the financial burden of patients. But one thing I think we should really emphasize is the engagement by the state governments. I think this has potential to be scaled up and to affect more people. I'm rounding up in 30 minutes. Thank you. I think that should be scaled up and rounded up as well. So as I close, I would say that is one strong recommendation that I think NICRAT should consider.
Thank you so much.
So thank you, everybody, to all the people that have participated. Your thoughts and your contributions could not have made this session a better one. Thank you so much.
Please, a round of applause for them, please. Dr. Wachuku, please, you take over for the next session. Thank you.
Good afternoon, everyone. Following a very interactive session, I think the questions and answers could go on forever, but it shows that, there's a lot of engagement. So you're welcome to the implementation science session. We have to bring this before the Pfizer session, as our presenters are looking to travel. So I would like to call Dr. Ejemai Eboreme and Professor Juliet Iwulemo to please come up. Are they here? Oh, they are virtual. Okay, Professor Juliet Iwelumo, please, can you unmute so that you can start your presentation? Dr. Juliet Iwelumo is a professor of global health at the Department of Behavioral Science and Health Education at St. Louis University. And her research is centered around the use of culturally salient implementation science strategies to develop, implement, and sustain in the community setting evidence-based health interventions that reduce health disparity and advance health equity. So which is really important as we speak about equity in oncology. So that's the reason why we're looking at implementation science to help in equity. Is she online? Okay, please unmute. If you can hear me. Dr. Juliet, if you can hear me, please unmute. Has she done that? Okay, how about the second speaker? Dr. Juliet, one more time, can you hear me? If you can, please unmute so that we can start your presentation. Okay, all right. Did she share her slides, or you're going to give her permission to share? Dr. Juliet, if you can hear me, you can start. Please, we're giving you 15 minutes for your presentation, and then we'll have another 5 minutes for question and answer. Can you continue? Okay. Oh, you can't hear. They said somebody online said they can't hear. Hello, Prof. Hello, Prof. Hello, confirm if you can hear me.
Hello.
Okay.
Can you hear me? Hello.
Yes, Prof, we can hear you. Can you hear us now?
So I could not hear a word of what Ella said at all, and I've been sending messages across. Please let us hear. Many of us online. Nobody bothered to read what our comments. We cannot. No sound. No sound. Not even a word of what Ella said.
Okay, sincere apologies.
We don't know what you are doing now. It's very bad now. Abba, we'll be here all morning, all day. We send messages all over.
Well, I can hear. Good morning. I can hear now.
Is that Prof?
Yeah, I wasn't hearing before, but I can hear now.
Well, I can hear you now. Yeah, but what are we discussing? We have no idea.
Where are we? I don't know where we are, too.
Yes. We have no clue. Since Ella spoke, we had nothing, not a word. And I sent messages around. Pleading, phoning, please, unmute, so that we can hear. We're all muted here. So we don't even know where you are. What are you saying now? We don't know.
What?
The chairman of the BOT, we sincerely apologize. Presently, we are taking the implementation science, and we have an online presenter, sir. Dr. Wanchuku is coordinating the session, sir. And we sincerely apologize to all our members and our guests online. And we are having some little technical glitch, but please kindly bear with us as we attempt to proceed. Thank you very much, Prof. Sir.
Hello, Professor Juliet. Can you hear me? Okay, thank you, and we can see you. So please, can you share your slides, unmute, and so that you can start your presentation. We have 15 minutes for your presentation, and we'll give you another 5 minutes for question and answers. So Professor Juliet will be speaking to us on implementation science in cancer control, an untapped opportunity for promoting equity in cancer prevention, training, and research. Thank you.
Can you disable the sharing? It's still, I can't share screen.
you very much, Professor Juliet, for a very exciting presentation. I don't know about other people in the room. Implementation science is really new to us here in Nigeria. I remember my first interaction about implementation science. I was like, this is an area that, you know, I don't really have enough experience about. But it is exciting, and I think it's the way to go. If we're looking at research, it's not just the research, like she said. We need to close the gap between research and, you know, practice. Something that was very interesting that she said was that it takes about 17 years for research to go into practice. I think that's really long, and it's a gap that we really need to close and shorten. Do we have any questions for Professor Juliet, please? Any questions? Aha. Okay. I also found your leaky pipeline very interesting. It's something that I found as a recurring issue in most places in cancer care. So most people try to find where the leaks are to be able to block them to prevent leakages from continuing. So, but the thing is, like you said, with the cracks, you block one crack and then several other cracks open up, and we have to find a way to keep blocking them so that we can quickly travel from research to put it into practice. So thank you very much once again for a very wonderful presentation. Okay, so we have questions. Thank you.
My question is, like Dr. Adela mentioned, we are not very familiar with science, this part of the world really, but I think it's actually coming up and there's more interest. But my question is, how do we get into mention science? I mean, what are the steps? There are criteria, we need to know about it. So that for those of us who actually want to probably do some work in that area of research, so we know what to do, what we have to get, and how to get into mention science. Those are the criteria and the steps to go into mention science. That's my question. Thank you.
Okay, thank you. Professor Juliet, did you hear his question? Is she still online? This is really exciting. I'm also happy to hear that you are involved in grant writing. We will reach out to you to also assist us for grant writing because we are moving into a lot of research now. The next presenter, Dr. Ejemaye Borime, is unable to join us due to the time conflict. So, we have another question. Okay.
Hello, I'm Dr. B. Yolu today from Port Harcourt. While you were speaking, and thank you for your presentation, you had mentioned about simplifying implementation science, and you did make reference to some tool. I was wondering, are there other tools that can simplify implementation science that you're aware of, and also on how to get access to some of these tools? Thank you.
First, there's a paper by Jeffrey Coran that makes it I actually used to teach that, but I took it out of my slide. But there are so many other tools that simplifies it and makes it easy that I can share when I share my slides, those resources if people are interested.
Okay, thank you. We look forward to having your slides. So let's give Professor Juliet another round of applause for a wonderful presentation, and we've come to the end of the implementation science session. Thank you.
So thank you very much, Dr. Nwachukwu, for chairing that session. So next, we'll move on to the Pfizer presentation. This will be chaired by Dr. Sam Otene. The presenters are Prof. Bello and Prof. Tessie Nwaga. Please, can we have you up front? Can we have the speakers up front, please?
All right, thank you. Thank you very much, Dr. Jimeta Desri. I think it's even a little bit more because there's an addition. I was given an addition. Dr. Mutiu Jimo. Is Dr. Jimo around? All right, thank you. We have just 40 minutes for this, ladies and gentlemen, and we would want to be as brief with it as possible. It's just mentioned as Pfizer presentation on the program, but each of the speakers has a topic that they will be speaking on. Professor Tessie Nwaga will be Professor of Hematology. I will be calling you up first, and she will be talking to us, Professor of Hematology at UNTH, Enugu. She'll be speaking to us on cancer-associated thrombosis, right, ma? All right, thank you very much, ma. I was told we have 40 minutes. That means we would have about 10 minutes each to speak so that we can have 10 minutes to spare for questions. Thank you, ma. Okay, maybe I'll give you this mic.
Good afternoon, everyone. I'm really pleased to be here with you this morning, and I can say that it has been quite an engaging session. But as a coagulation specialist, I made an observation while sitting in the hall. Not many people were actually moving around. A lot of people have been seated since I came this morning. And as we are going to talk about cancer-associated thrombosis, it is also good for us to care about ourselves and the fact that we also have risk for thrombosis, and would crave on the indulgence of the LOC to see that we interject some minutes for people to stand up and walk around during these sessions. I have been entranced all morning, so let me jump right into it. So this afternoon, I'm giving this talk on behalf of Pfizer, and I'm going to talk about, I'm going to talk about cancer-associated thrombosis, the role of a Pixaban, which is a DOAC. So these are my affiliations, and also these are my disclosures. So cancer-associated thrombosis means abnormal clotting in the blood vessels, and it occurs frequently in persons with cancer. Most of these clots are in the veins, not the arteries, and when they're in the veins, they can affect the deep veins, and they can also cause pulmonary embolism. Together, this term is called venous thromboembolism. It's not working. Sorry. Okay. So next slide, please. All right, so what is the burden of VTE in patients with cancer? Cancer is associated with venous thromboembolism, and there is 4 to 1-fold risk of thrombosis. As oncologists, as treaters, we should take note of this. Also, when we put our patients on chemotherapy, the risk also increases to 6-folds. And together, this causes an annual incidence of 1 in 200 cases of VTE in cancer patients. So why do we really care so much about cancer, thrombosis in cancer? Because studies have shown from Pradoni et al. That there is a higher rate of VTE recurrence in patients with cancer, and there's also a higher rate of bleeding in patients with cancer. And because of this, next slide, please. All right, sorry. Could you go back? Go back, go back. Yes. And because of this, and that is why we consider cancer-associated thrombosis quite serious. One, because there's a higher mortality among cancer patients with VTE than without. It can cause delays when a patient with cancer develops thrombosis. It can prolong hospitalization. It can compromise outcomes. Throughout the morning, I've been hearing about people that have survived cancer, that have done that are living without cancer, or people that have good outcomes. When there is thrombosis, all this goes down the drain. It can also compromise outcomes for surgery, and 1 in 10 persons with cancer can develop a blood clot. Please note that for the different cancers we have, they also have different risk. And as such, the import of risk assessment cannot be overemphasized. So anticoagulation therapy on its own, when there is cancer-associated thrombosis, is associated with a higher bleeding risk. Next slide. So over the years, there's been a paradigm shift from just having one drug alone that we use for the management of cancer-associated thrombosis. We've gone through the VKAs, the low molecular weight heparin, and we are now in the DOACs, the direct oral anticoagulants. Next slide. So this afternoon, I'm going to talk about apixaban, which is an anti-10A inhibitor. Apixaban as a DOAC offers a new perspective for cancer patients in need for anticoagulation. You'll be asking, apixaban is a DOAC. Why? What is so special about apixaban? The evidence, the available evidence is what makes it special. In fact, there are 2 clinical trials, the Cassini trial that tested rivaroxaban versus a placebo for thromboprophylaxis, and the AVET trial that tested apixaban versus a placebo. And all these trials have shown that the results are concordant with a consistent result that these DOACs do reduce the incidence of VTE. Next slide, please. So this is the trial mode roadmap for cancer-associated thrombosis. They've had a lot of trials, but please note the Caravaggio trial of 2020. That is the largest clinical trial on a DOAC concerning persons with cancer till date. Next slide. So what makes apixaban special? Let's start with the Adams trial. The Adams trial showed that there was 0% major bleeding in the apixaban arm versus the dalteparan arm. And it equally shows similar or slightly reduced major bleeding or clinical significant bleeding, and also the recurrent VTE. This got the whole world excited that there is a drug that you can take and it will not cause bleeding complications. And another thing that was significant with the Adams trial was that they tested people that had metastatic cancers and people that were already on chemotherapy. Next slide, please. Next slide. So the conclusion from the Adams trial showed that oral apixaban was associated with low major bleeding and VTE recurrence rate for treatment of VTE in cancer patients. That is, for those that have been managing VTE in cancer, that is like the game changer. Next slide. Then we come to the Caravaggio. A lot of people didn't really believe the results from the Adams trial. They talked about the small sample size. They talked about, oh, is this data real true? Then in 2020, there was the Caravaggio trial that tested a total of 1,170 persons with cancer. And they were randomized into the apixaban group and the dalteparan group, and they were followed up for 30 days. Next slide. So the results was also amazing. They found out there was a significant non-inferior result concerning the recurrent VTE. Those in the apixaban group had low episodes of recurrent venous thromboembolism than those in the dalteparan group. You may be wondering what type of drug is dalteparan. That's a low molecular weight heparin. We also looked and we found there was also reduction in the major bleeding, and there was a slight increase that was not significant in the clinical non-relevant clinical bleeding. Fine. Then, next slide. What was the outcome of the Caravaggio trial? One was that the apixaban was non-inferior for primary composite endpoints compared to the low molecular weight for treatment of VTE and DVT in patients with active cancer. It was actually this trial and Adams trial that made societies to add apixaban as one of the DOAs that can be used in the management of VTE. It equally found out that apixaban was non-inferior. Next slide, please. Next slide. Next slide, please. So, there are times in the management of your cancer patients that have developed thrombosis. You would want to extend beyond the regular 3 to 6 months. But most of the times there have been no data about how safe it is to extend beyond that 3 months. Please, next slide. So in 2023, at the ISTH conference, they reported the EVES trial, where they found out that apixaban is safe and equally effective when given over a 12-month period, whether you give it at 2.5 or 5 milligrams. Next slide. So these were the trial endpoints results. Next slide. So the conclusion was for extended secondary prevention of cancer-associated VTE, that 2.5 milligram was associated with a combined rate of major plus relevant clinical bleeding at a rate of 8.5 for 2.5 milligram versus 12.2% for 5 milligram. Next slide. Next slide, please. Now let's come to the real world evidence. And the real world evidence was what makes apixaban special. They compared apixaban versus rivaroxaban, which is also a DOAC, to find out which ones had better safety profile when it comes to recurrent VTE and bleeding. And they found out that apixaban was associated with a lower risk, which makes it the game changer when you want to manage persons with cancer-associated thrombosis. And it was also associated with a lower risk of intracranial hemorrhage and a gastrointestinal hemorrhage, as far as also recurrent VTE. compared to rivaroxaban. Next slide. So what are the take-home points? VTE is common and is a life-threatening condition in cancer patients. You should not ignore this because most times it will mess up your practice and it will mess up your management. And that is why it is important for us to risk assess our patients at all times. The occurrence of VTE has been reported to increase the likelihood of death for cancer patients. And now we have a wide spectrum of anticoagulant agents to use. But apixaban has been found to be efficacious, have a good safety profile, even when compared to its fellow DOACs, and is non-inferior to low molecular weight. So why won't you use apixaban in management of cancer-associated thrombosis? And not to mention that it's orally administered. Next slide, please. I'll have to end by reminding everybody in this hall about October 13th, and that is the birthday of Dr. Rudy Vakau, who is a pioneer for describing thrombosis. So on October 13th this year, we'll be marking the 10th anniversary of World Thrombosis Day. And I'm calling on Arcon to ensure that they celebrate this day because globally, everyone that is associated with thrombotic medicine will be celebrating World Thrombosis Day. Thank you for listening.
Thank you very much, Prof. You did fantastically well. You hit the time right on the head. We won't take questions until all the presentations are through. So I would want to call on my boss, Professor Bello Abubakar, consultant radiation and clinical oncologist at National Hospital Abuja. He will be talking to us on the treatment of locally advanced or metastatic HER2 breast cancer with a BRCA or BRCA1 or BRCA2 mutation. There's only one mic.
Thank you very much. My slide up. So before the slide comes up, can I ask a few questions here, please? How many of you that treat breast cancer have reasons to do BRCA testing? Anybody? Anybody? And how many centers in Nigeria can actually do BRCA testing? Can I see? Any hospital, government-owned hospital? Not that I know. Okay. So this is very important that when you are treating especially triple-negative breast cancers as well as some hormone receptor-positive breast cancer, that you may want to do a germline BRCA mutation testing. So I'm taking, this is more like the Best of San Antonio Breast Cancer Symposium that was conducted sometimes in 2072, and I'm going to be discussing the mBRCA clinical trial that was presented by Litton et al. Next slide. So mBRCA, I don't have pointer. How do you move it? Up? This is down? Okay. So the mBRCA study design was for patients with locally advanced or metastatic HER2 negative breast cancer and a germline BRCA1 or BRCA2 mutation. And the stratification factors was the number of prior chemo regimens. Some have more than one, triple negative breast cancer or hormone receptor positive breast cancer, and a history of central nervous system metastases or no CNS metastasis. Those patients were stratified 2 to 1. Those that have talazoparib, 1 milligram per ounce daily for a 21-day cycle, which is continued until disease progression or unacceptable toxicity. And the other arm is physician's choice of therapy, whether patients were given capecitabine, eribulin, gemcitabine, or vinorelbine. And the primary endpoint was progression-free survival by RECIST by blinded central review. Other key secondary endpoints are overall survival, objective response rate by investigator, as well as safety. And exploratory endpoints were duration of response for objective responders and quality of life. Quality of life was assessed through the quality of life questionnaires through European Organization for Research and Treatment of Cancer, as well as quality of life questionnaire for breast cancer modules, as well as quality of life questionnaire quartet. This was a phase 3 international open-label study randomizing 431 patients in 16 countries in 145 sites. Unfortunately, I don't think Africa was part of the study sites. I haven't seen. So this is something that we want to really complain to Pfizer. Hopefully that going forward, that part of Africa will also be included. What is the basic characteristic of the intent to treat population? Median age is ranging between 27 to 88. Gender is only females, and the ECGO score of 0, 1, or 2%. And measurable disease, you can see it's about 219 in the talazoparib arm, while it's 114 in the physician choice of therapy. Hormone receptors are fundamentally triple-negative breast cancers on HER2 positive, and BRCA status are BRCA1 positive or BRCA2 positive. In the talazoparib, the BRCA1 positive is about 133, while BRCA2 were 154. And the disease-free interval was over less than 12 months. So prior therapies for the advanced diseases, those that had prior adjuvant and neoadjuvant therapies in the talazoparib arm were 238, while in the patient's choice of therapy, there were 121. Prior hormonal therapy for the hormone receptor positive patients were 161 in the talazoparib arm, while there were 77 in the patient's choice of therapy. Prior platinum therapy was 46 in the talazoparib arm, while there were 30 in the overall patient choice of therapy. Number of cytotoxics was also considered, more than 3. Okay, more than 3 were 12 in the talazoparib patients, while in the overall patient physician's choice of therapy were 6. So I will go quickly. Patient disposition, whether they have received treatment or not, and we have also looked at primary reason for discontinuation of drugs. Some are adverse events, death, progression of disease, withdrawal by subjects, physician's decision, and so on. This is also, so the study drug exposure, the median duration of treatment for the talazoparib was 6.1 months. For the overall patient's choice of therapy was 3.9 months. And you can see the stratification according to drugs. Capecitabine had 4.1, eribulin 2.9, gemcitabine 5.5, while vinorelbine is 4.2. The median relative dose intensity in percentage, you can see 87.2, 87.9 respectively. So what was the endpoint results? The progression-free survival by blinded central review we can see that in the talazoparib arm, we have 8.6 months as compared to 5.6 months in the patient's choice of treatment. And this actually has continued. Looking at this is the progression-free survival subset analysis for patients that have CNS, patients that have had prior platinum therapies, and so on and so forth. I'm running fast because of the time. And then those that have CNS metastasis subgroup also have a median survival of 5.7% months, in the talazoparib arm as compared to 1.6 in the overall patient's choice of therapy. So you can see that there is significant benefit with the use of talazoparib even in patients that have CNS metastasis as compared to the use of chemotherapies. Secondary endpoint, which is overall survival analysis. You can see in the talazoparib arm, you have up to 22.3 months as compared to 19.5% in the physician's choice of therapy. So survival probability at 24 months in the talazoparib arm is about 45% as compared to the chemotherapy arm, which is the physician's choice of therapy, that is 37. So there is significant improvement compared to chemotherapy when you use talazoparib in those patients that have BRCA mutations. Looking at other secondary endpoints, overall response, when you talk of complete response, you have up to 12 in the case of talazoparib, as to none in chemotherapy patients. Partial response is about 125, stable disease about 46, those that could not be evaluated about 4. Objective response also is quite significantly high, almost double in the arm of the talazoparib as compared to the patient's choice of therapy. Also, duration of response is much more significant by investigators' assessment when you see that in case of the talazoparib, there is a 1-year probability of sustained response, which is up to 23% as compared to 0 when you compare it with the physician's choice therapy arm. Adverse events, mostly hematological. Anemia is number 1, followed by neutropenia, and even febrile neutropenia is literally almost very low and is not seen mostly in the talazoparib arm. Next. Okay, non-hematological side effects as well are there, and then, of course, serious side effects are really not seen in the talazoparib arm as compared to the other arm. What of quality of life? Patient-reported global status health. You can see that in the talazoparib, the estimated overall mean change from baseline is almost 3 with a p-value of 0.001 as compared to the negative improvement in terms of the patient's choice of therapy. So in conclusion, so BRCA is the largest randomized trial evaluating PARP inhibitor in patients with advanced breast cancer and a germline BRCA1/2 mutation, and talazoparib resulted in prolonged progression-free survival and physician's choice of therapy by blinded as compared to physician's choice of therapy by blinded central review. All key secondary efficacy endpoints demonstrated benefit. With talazoparib, overall survival is immature. The number of follow-up is still ongoing. The global health status and the quality of life showed overall improvement from baseline and a delay in the time to clinically meaningful deterioration in patients receiving talazoparib. So talazoparib was generally well tolerated with minimal non-hematological toxicities and adverse events resulting from in-treatment discontinuation. I wanted to quickly talk about also the use of talazoparib in metastatic castration-resistant prostate cancer, but time will not allow me. But suffice to say that it is also used in prostate cancer, especially when you are able to do homologous recombinant repair deficiency testing. The panel is about 12 mutations, and it will be wise to see them going forward. Maybe we can discuss it during question and answers. Thank you very much.
I know Prof very well. If I give him 2 hours, he will still be on this. Thank you very, very much. Dr. Mutiu Jimo, as I call you up, just know that Prof has taken 2 out of your 10 minutes already. He will be talking to us on the Paloma trials and Palbosi.
Yeah, thank you very much. Good afternoon, everyone. Is this slide on now? Okay. Well, before they put on my slide, what I want to discuss this afternoon is the review of Paloma trials and practical experience in the use of palbociclib in the management of hormone-positive, HER2-negative metastatic breast cancer in the Nigerian population. Right, where it has become the gold standard that addition of CDK inhibitors to anti-estrogen is very important in the management of hormone-positive, postmenopausal, advanced breast cancer or metastatic breast cancer. So this Paloma trial is an ongoing trial in the management of breast cancer, and it's a phase 3 study that was designed to confirm and expand the efficacy and safety data for palbociclib plus letrozole as first-line therapy for postmenopausal women with hormone-positive breast disease. The cycling interaction with CDK4 and CDK6 that facilitate the hypophosphorylation of the retinoblastoma gene product and leads to progression of cell from G1 checkpoint to S phase. And if there's an alteration of this pathway, usually leads to loss of retinoblastoma checkpoint. And this loss of retinoblastoma checkpoints has been described in a number of malignant conditions and are associated with endocrine resistance in breast cancer. So the alteration includes this, mutation or loss or both. And the palbociclib, Ibrance especially, is a small molecule inhibitor of CDK4 and CDK6. The preclinical studies of palbociclib have shown its ability to preferentially inhibit the growth of estrogen receptor positive breast cancer cells and acts synergistically with anti-estrogens and the reversal of the endocrine resistance disease. The Paloma trial, Paloma 1, usually shows significantly longer progression-free survival with palbociclib and letrozole in one arm compared to letrozole alone. And then the Paloma 2 is a larger study of this Paloma 1. It was designed to confirm the findings of Paloma 1 and to further assess the safety and efficacy of palbociclib. So the study design is a randomized, double-blind, placebo-controlled phase 3 efficacy study to assess the safety and efficacy of Ibrance in combination with letrozole, as well as first-line treatment of postmenopausal women with hormone-positive disease, advanced disease or metastatic disease. Now, these are the randomization is in 2-to-1, ratio 2-to-1, the Ibrance with letrozole arm, treatment group, and the letrozole only, and the primary endpoint is investigator assessed free survivor, the progression-free survivor, which this study met, and also the secondary endpoints, with the use of Ibrance of 125 milligram orally, and then letrozole 2.5 milligram orally. The Ibrance is for 21 days, then 7 days free, and making it 28 days cycle. Then these are the inclusion and exclusion criteria. The exclusion criteria, when patient has a very serious systemic involvement, like visceral metastasis in lung or liver that are very serious, or CNS metastasis, then they exclude those patients. Now, the baseline characteristics are very similar in both treatment groups. The Ibrans plus letrozole and the letrozole plus placebo, they are very similar. Age, the ECOG status, disease-free intervals, and like. Then looking at this graph is showing that the median progression-free survival is better in palbociclib letrozole treatment group compared to letrozole alone. It's about 24.8 months to 4.5 months in the letrozole group. Then we're looking at people that have metastasis. They also look at their survivor with the treatment group of the palbociclib with letrozole is also more, despite the metastasis to the visceral organs, compared to the only placebo and letrozole. Then, patient with bone metastasis, because the disease burden here is less compared to liver or lungs metastasis. In the patient I want to present, the patient had only bone metastasis. We are going to see. So there's a reduction in the risk of disease progression in this arm. Patient with Ibrans and letrozole compared to letrozole alone. Then looking at the tumor response, the treatment groups is better compared to the only placebo and letrozole. We can see the clinical benefit rate and the objective response rate in both two arms. We also tested in elderly above 65 years, and the adverse effect is consistent with the known AE profile of Ibrans. So there's really nothing to worry about in using it at this age group. Even longer term safety, patient can use it as long. Like patient I want to present now has been on it for more than 3 years and is tolerating it. Then the safety also in patient with visceral metastasis is also according to the trial that is really it doesn't really mean that if patient has visceral metastasis or lung or liver, they cannot use this drug. They can still use the drug. Then the cardiac safety, we don't really monitor this. The only CPC is the only one that we monitor when we are administering this drug. Then looking at adverse effect, the one on the treatment group of Ibrans and letrozole that was observed is the neutropenia. Neutropenia, the anemia, compared to the other group. That's why it's very important for us to do CBC, and then we monitor that when we are treating this patient. So they notice that in that group. The same here. So it's similar. This adverse effect is similar in both treatment group. So the dose usually comes in formulation of 100 milligram or 125 milligram. We usually start with 125 milligram, and then in addition to anti-estrogens, or we can also use with fulvestrant if patient has a progression of disease with the normal aromatase inhibitors, letrozole or anastrozole. And this is the dose. Then, like I said, CBC is the only scheduled monitoring provision included in this trial. And we will monitor that when patient is on it. For the first 2 cycles, they monitor the CBC before the patient starts, and the 15 of those ones. Thereafter is once in a month. The conclusion of this, the palbociclib is in combination with ET, improved progression-free survival and quality of life in patients with advanced breast cancer, including severe patient subgroups. So we can see from there. Then quickly, in the next 1 minute, this is the patient that presented to us. This patient was diagnosed in 2016 with invasive ductal carcinoma of the breast. Right, so she had AC 4 cycles with weekly paclitaxel of 12 cycles and completed in 2017. And then traveled to South Africa to have wide local excision and axillary node sampling and the reduction mammoplasty, bilateral. Though it's the right side that had issue, but they did bilateral mammoplasty for the patient. So patient also had brachytherapy in addition to the wide local excision. So he was placed on Arimidex until December 2018 when she progressed. So she presented with local recurrence, the recurrence from the tumor site, and it was biopsy and then confirmed recurrent disease. And this patient was also, we investigate further to see if there's any tumor somewhere else, and then the CT, the bone scan, show evidence of bony metastasis. So this patient had biphosphonate for 2 years and has been on the paclitaxel plus fulvestrant for over 3 years now. So I saw the patient last week Friday, and he's doing very well with it. He's due for another one on the 19th of this month. Thank you very much.
Thank you very much, Dr. Jimo. The first time I heard about Paloma study, I thought they were talking about a Mexican movie or something. We have just about 5-7 minutes to ask questions. I will take just 3 questions. If you are unlucky and you have all the 3 questions directed at you, well, so be it. But we will be happier if they are spread, at least one for each of the speakers. And it's not like we must ask questions. If there's no question, we have saved ourselves 7 minutes so that we can move ahead. So I'm looking for hands for asking of questions. Usually after a lecture, if there's no question, it's either the lecture is so well understood or it's not understood at all. I think we should give the presenters a round of applause and move to the next session. Thank you very much, Professor Bello. Thank you very much, Professor Waga. Thank you very much, Dr. Jimo. Who am I handing the microphone over to? And thank you very much, Pfizer, for the wonderful drugs that you are bringing forth to help improve our practice of clinical oncology. Thank you.
So thank you so much, Dr. Sam Otene, for chairing that session. So we'll move very quickly to the next session, which will be chaired by Professor Sunday Adeoyi. The session is the best of ASCO. It's a 1-hour session. So can we have the speakers who will take us on that session, the best of ASCO? So Prof. Adeoyi, please, sir. The speakers are Dr. Joseph Adedayo and Dr. Samuel Otene. Now, immediately after lunch. Now, so if you come after. Oh, so Prof. So sorry, there's a slight change. So we'll have lunch now. Lunch is ready, and then we'll take the best of ASCO after lunch. So lunch, we'll try to make lunch as quickly as possible, 10-15 minutes. We should be back down. So so we are expected back here between 4:15 and 4:20. So lunch is ready. Like we don't need lunch. I think I see everybody's still seated. So let's tidy up the lunch session. So we'll be back here between 4:15 and 4:20. Thank you. Yeah, so we are reminded to go along with our meal tickets. It's in the booklet.
hold it down.
The lunch is downstairs, the same venue as yesterday. So good evening, everyone. We are almost set. So Dr. B, are we good to go? Okay. So welcome back from the lunch break. So we'll move very quickly. We'll call on Professor Sunday Adeoye to chair the next session, which is the best of ASCO. The speakers would be Dr. Joseph Adedayo. We know she has a keen interest in pediatric oncology. The paper she represents in this one. Yes, so the next speaker would be Dr. Samuel Otene. Please, can you kindly move forward? So we'll try to wrap up this session in about so it's 40 minutes.
And I'll do my own. Ladies and gentlemen, you are welcome back from the lunch meal. We have 40 minutes for the next segment. I am your humble self, Sunday Adeoye. You are welcome on board. Speaking first is Dr. Joseph Adedayo. Your time starts. Please, can you post the slides of Dr. Joseph Adedayo before I start timing her? We need to manage time very well.
Thank you. Hello, everyone, and welcome back from lunch. And thank you for your attention and time.
Okay, this one is
Thank you.
working.
Let me just test this. Okay. So thank you for your attention. Thank you to the organizers for remembering to include pediatrics in the program. That tends to always be the overlooked specialty, isn't it? So this abstract just summarizes the results of a collaboration between a hospital in an LMIC and an HIC. And it starts by showing you the distribution of pediatric cancers globally. And as you can see, there's a disproportionate tendency towards low middle income countries. But what I want to draw attention to is the curves. So if you see the two curves, the blue one, the dark blue one, is survival rate in high income countries. And you can see the trend from 1950 to 2020. And you can see how the survival rate has climbed steadily. And then you look at the survival rate in low middle income countries, which is the pale blue line. And when you first look at this graph, you might miss it because, and I think it's very symbolic, it has flatlined. So between 1950 and 2020, survival rate has not really improved in low middle income countries. Just look at how the gap has widened over the years. And I think that's really tragic. And it's really, really representative of the truth that we all know. We all know that this is what is going on now. It's not changing. Can you change to the next slide, please? Okay, so the background talks about pediatric leukemia. I'm not going to go over this. We all know outcomes are poor, but if you read a pediatric oncology textbook, one of the first things you will see is that pediatric leukemia is one of the most curable cancers in the world. But then I remember I was having a conversation with an international colleague, and I said they need to add a line there that says it's one of the most curable cancers in the world in high-income countries. That isn't true for us, obviously. And ALL is the leading cause of death among children in LMICs. And I can speak to this personally in my personal journey working in pediatrics. I work with a nonprofit that supports children with cancer financially. And at some point, we had to make a decision to not put funds towards treating children with leukemia, children diagnosed with leukemia in Nigeria. Because the unfortunate truth was we would raise the funds, but over a course of 3 years, we helped 15 children and all 15 of them died. And so when you go back to the funder, they don't want to support you because they believe the children are going to die anyway. So we had to take our money and start putting it in Wilms tumors and retinoblastomas. So you have almost a 90 to 100%, mortality rate for leukemia in LMICs. But going to the point, this is a twinning model of a well-established center with years of experience, with expertise, infrastructure, and with proven survival rates, twinning with a center in an LMIC to develop capacity to, bring their good rates to the LMICs. It was established in 2008, and they picked one cancer, which is the ALL. And they worked using the WHO framework, patient-centered care, which encompasses everything: chemotherapy, access to medicine, supportive care, radiation oncology, pathology. And we all know that without all of these things, you cannot cure pediatric cancer. And they had a pre-implementation period, and I found this really, really interesting, from 2008 to 2012. And it just shows you how much time, work, effort, and thought went into this project. It's not something you just get up and do overnight. And they had a period of pre-implementation, and then in 2013, they started the program. So over that period, 109 children were treated at the hospital in Mexico, in Tijuana. And the average age was 7, sex distribution was even, and 70% of those children had high-risk disease, and we all know the features of high-risk disease. And what were the outcomes of this program? They had a fully staffed leukemia service. Fully staffed meaning that these people have been recruited, they have been trained, they have been empowered, and they know how to do this. The program was sustainable at the end of the day. It was evidence-based and data-driven, and there was support for funding, medications, and all of that. And they sort of divided the implementation into blocks. So block 1 was, putting in place an early warning system, training the staff on how to use it, reducing the central line associated infection rate, putting in place the protocols. In block 2, they started the training phase, empowering the health workforce to be able to implement it. Block 3 was about the information systems, data. And anybody who spends time around me now knows that that is my mantra now. Your data is as important as your practice. If you are doing something good and you're not documenting it and you're not recording it, there is no way you can sustain it. You don't even know what you're doing good if you don't examine it. So there's no way you can keep it up. And more importantly, you can't replicate it if you don't document it. Block 4 was access to medicines. So again, this is a reminder that you have to have the perfect intersection of clinical practice, policy, financing, and leadership for you to be able to change anything. And these curves just show how the overall survival improved in that period. So they went from 59% to 65% overall survival in just a period of 5 years over treating 100 children. And these are indicators of sustainability of a program. And if you look at it, as of 2013, which is the green bars, they were not meeting up to 50% of any of the targets. And as of 2017, they're reaching the maximum score on several of those targets: benefits beyond helping patients, credibility of the evidence, staff behavior, senior leadership engagement, clinical leadership, So it was not just about administering treatment, but the important thing is to make sure that that program can continue, can outlive the people who started it, and it can be replicated in other centers. Future directions, and this speaks to what we're talking about, that the model serves as an example for future global partnerships aimed to establish pediatric and adult cancer services in LMIC. And I just wanted to point out that, so these people, they had this partnership, they documented their results, and they've shared it, they've disseminated it. And the point is this: if you've done it, your publishing it is a blueprint for another center. We can now look at what they did and copy it and adapt it and learn from it. And when we don't share our results, that's what happens. Future initiatives, implementation of standardized approaches for data collections, cancer registries and surveillance systems, building of sustainability, patient-centered care, mitigation of socioeconomic barriers and financial toxicity. And I'm going to talk a little bit about this tomorrow, but the point is that we tend to, as clinicians, we tend to focus on the clinical aspects of treatment. And we forget that, especially for the pediatric population, the family is important. You have children who have paid in full for their radiotherapy upfront, default from treatment halfway through. And you just wonder, why would you have paid for treatment and then not complete it? And it's because the family ran out of funds, or the younger brother was sick, or they had to travel back home because they had abandoned their other children. So you can't successfully change pediatric cancer, implement a pediatric cancer program, if you don't remember the family. If the family isn't properly educated, if the family isn't properly supported, if the family isn't properly involved, you're going to lose that child. And you're going to lose that child to loss from treatment, loss to follow-up, or some other loss. So conclusions. The Twinning plus WHO Framework for Action model focused on sustainability was effective in reducing leukemia survival disparities, meaning that the disparity between high-income and low-income countries was closed. And I do have to say that they were starting from I wouldn't say great, but 59% survival is actually better than what you find in many LMICs in sub-Saharan Africa. So they weren't even starting from zero, and they were able to improve that. 6 building blocks systematically addressed key strategies to improve ALL outcomes in LMIC. Training. Yes, we talk about training all the time, but there's multiple types of training. There's the remote training, but then there's also hands-on and being present physically. And you can say that proximity helped here, but the truth is, if you can fly 1 hour, then you can fly 6 hours. And now we live in a post-COVID world where you can connect across time zones and continents remotely. Adaptation of protocols, supportive care, ensuring treatment adherence, that is important. If the family isn't involved, you're not going to have treatment adherence. Reduction of financial toxicity, making sure that accommodation, transportation, food, and all of that is provided. In pediatric cancer, these are things that are not negotiable. Geographic proximity, mentoring, data-driven projects, capacity building. All of these things came together to lead to sustained improvements. I think I've summarized it well enough. I don't think I need to go over this again, but just to show here, it takes a village. To change pediatric cancer outcomes, you need clinicians, you need policymakers, you need funders, you need non-profits, you need social workers. There's so many people who have to come together in a village for pediatric cancer outcomes to improve. Thank you.
Thank you very much, Dr. Joseph, for keeping to time. Please write down your questions, and then we'll move to the next speaker, Dr. Tene Samuel. Next slide, please.
Yeah, good evening, everyone. We're here again. I'm presenting the abstract 4006 that was presented at ASCO 2003. I think best of ASCO is about presenting these slides, these abstracts, just to help us get up to date with some of the things that are happening. So what we are most definitely going to be seeing is hearing the voice of Jacob, but seeing the hand of Esau, because you are not going to see my name on this presentation at all, because these are not our studies. And it's just an additional result on the phase 3 Napoli 3 trial. That was a trial on Nalirifox versus nab-paclitaxel plus gemcitabine in the treatment of naive patients, patients who have not been, patients with metastatic pancreatic ductal adenocarcinoma who have not been exposed to previous cytotoxic chemotherapy. therapy. If I do this, I expect us to go to the next slide. I noticed this didn't work when she was presenting, so I didn't bother. All right. You know, like I said, it's an additional information based on the extra time beyond the initial presentation of the Napoli 3 trial. So that trial was already presented at, you know, at an ASCO gastrointestinal cancer symposium in 2023. But about 6 months thereafter, additional information was gathered, additional data was gathered. So this abstract is just specifically to present those additional information. But this Napoli 3 trial, like I said, is on metastatic pancreatic cancer. And we all know the very dismal, the very poor picture that pancreatic cancer actually has, especially when it is metastatic. When it presents ab initio metastatic, we usually give the patients in our own setting somewhere between 3 to 6 months of, you know, probability of survival. So anything that we are able to win with an, okay, it's working now, yeah. Anything with which we're able to win an extra time to gain more survival now becomes an addition. And before now, the gold standard seems to be a gemcitabine-based chemotherapy for these patients, ab initio. And even when Nalirifox was, yeah, I'm just showing this. Even when Nalirifox was adopted, it was adopted as a regimen that is given after gemcitabine initial chemotherapy fails. So this study is talking, the Napoli 3 study is talking about using this combination as an initial startup, as your initial chemotherapy regimen that you give, not waiting for when the gemcitabine cytotoxic chemotherapy fails. This gives us an idea of the various countries that were involved in this trial. It's a global trial, and the study design for the Napoli 3 study was very simple. The inclusion criteria, the age of the patient should be above 18 years, confirmed pancreatic carcinoma, pancreatic ductal adenocarcinoma. It should be a metastatic disease. The metastasis should have been discovered within 6 weeks prior to screening. The metastatic lesions should be at least 1 or more, and then the patient's performance should be very good. Now, these candidates, 770 of them, were randomly selected and broken into 2 groups, one taking what we already know, the gemcitabine nano-paclitaxel group, and the Nalirifox group. We had, I don't think I mentioned that Nalirifox is a combination of liposomal irinotecan with the 5-FU-leucovorin and oxaliplatin. So these 2 combinations, the patients were randomized, and, you know, the outcome was studied as they went along. There were various endpoints. The primary endpoint was overall survival, of course, but there were secondary endpoints like progression-free survival, overall response rate. There were other exploratory endpoints that had to do with the patient's quality of life and various biomarkers, and lots of biostatistical information were gotten. The general or the summary of this study is the fact that it was noticed that there was a significant improvement in the outcome for those who started with Nalirifox as a first-line treatment compared to those who were on the gemcitabine nano-paclitaxel group. This draft talks about patient disposition. I'm talking because I intended to skip it. How many of the patients continued treatment? How many of the patients, what were the reasons for their continuation or discontinuation of treatment? But basically, this just gives us an idea of the baseline characteristics of all of these patients that were involved in the study. Now, the improvement, which is shown by what color is this now? Do I call it? I'm not good with colors. The line on the graph that is not white, right? We would notice that marginal increment. I was wishing that there was a pointer that I could use to point, where we would notice that this study actually talks about an extension of the values that were reported earlier at the 12th month of observation, extending it from 12 to 18 months and even all the way a little beyond 24 months. Now, initially, these data had been presented, if you look at 12 months, and we see that there is that clinically significant advantage of 45.6% compared to 39.5%. But this study, this additional data only goes on to show us that even in the extra months that we're adding from 12 months to 16 months to 24 months, we still see some significant benefit in using the irinotecan combination as our first line of cytotoxic combination for these patients compared to the gemcitabine arm of the group. Well, this is a subgroup analysis breaking each of the groups into their differences. But you see, apart from that initial advantage in overall survival, the advantage is still noted also in progression-free survival for these patients. You are talking of at 12 months, 27.4 compared to 13.9. And even beyond, down to 18 months, you still see that the majority, you just had about 3.6% progression-free survival for the patients on the gemcitabine group, while those on the irinotecan group had a much higher progression-free survival. That also goes along with tumor response. Those, if you look at the two studies, the difference might not look so much. But like I said, we are dealing with a tumor that on its own has a very, very bleak prognosis. So anything that we can get that has some statistical significance beyond what we are already practicing becomes something that is recommended. So you are talking of a duration of response that is moving to 7.3 as compared to 5.0 on the average. Now, with regards to subsequent anti-cancer therapy, those who needed to have another treatment of the cancer after their initial treatment seemed to have failed, maybe any other chemotherapy combination beyond the Nalirifox, you had about 50.5% of these patients needing subsequent surgery. You had just 0.3% of these patients needing subsequent surgery, 0.5% needing subsequent radiotherapy, and just about 50.5% of these patients needing subsequent systemic anti-neoplastic therapy. And for most of those that needed subsequent anti-cytotoxic chemotherapy, they actually had to fall back on the gemcitabine again as an additional therapy that could be given if Nalirifox combination fails. We're talking about treatment. We're talking about treatment emergent adverse effects. This gives us some analysis. If you look at it a little bit closely, you realize that there are actually slightly more treatment emergent adverse effects with regards to the Nalirifox groups as compared to the gemcitabine nano-paclitaxel group. However, all of these other adverse effects still fall within the range expected for the combination of the various drugs being used in this cytotoxic chemotherapy combination. And they are usually adverse effects that are relatively manageable. So in conclusion, Nalirifox as a combination demonstrated statistically significant and clinically meaningful improvements in median overall survival and progression-free survival compared to the gemcitabine nano-paclitaxel group. The 12 and 18-month overall survival and progression-free survival also favored this group over the gemcitabine nano-paclitaxel group. The overall survival and the progression-free survival benefits were consistent across key pre-specified source groups, and these results support the use of this newer combination as a new reference regimen for first-line treatments in patients with metastatic pancreatic adenocarcinomas. I don't think I need to talk about the acknowledgements. Thank you very much.
Thank you, thank you, thank you. We've had the two speakers. Before we progress, please sit down. Dr. Ntekin is supposed to co-chair this session with me, but he is on another official assignment. so it's not available. Now, please, I will be expecting your question, but I want to guide you in the direction of your question, if possible, that when considering best of ASCO, I want you to think about what is the take-home from the study. What is the take-home for us from this study? Number two, can we implement this study in our environment? Is the situation right, laboratory-wise, drug-wise, clinically-wise? Can we implement it? Number three, what are the challenges that this study posed that we identify, and then how do we now navigate around these challenges? So if you have questions, my time still remains about 15, 20 minutes. Yes, let me count the hands first. I've seen the big heavyweights are already raising their hands. Any resident that needs to ask question, let's do it in our own systemic way. The Ogas, once they talk, we cannot talk again. So I belong to the residents. Ogas, I will call you last. I will call you last. Residents, any question? Yes, one. Another person? Okay, one, two, and then the Oga is the last.
My name is Dr. Njoku from Luth. My question is for the first presenter. So you talked about what's called pediatric leukemias are one of the very curable cancers. And you said that their survival is better in high-income countries than in low-income countries. I didn't quite appreciate the challenges and the reasons why it's that way. I'm using the 15 patients that got funding because the first thing that will come to our minds is, lack of funds. So using the 15 patients that were funded and we lost all 15 of them, I didn't quite appreciate the reasons as to why we had those kind of challenges in our environment. Thank you.
Yes, thank you. My name is Dr. Emanuela Wachuku from National Hospital, Abuja. Thank you, Dr. Joseph Sanotene, for wonderful presentations. My question is for Dr. Joseph. So just to, in tandem with what Dr. Njoku was talking about, the pediatric patients, do you think that if we try to focus on pediatric cancer centers, if this will help, if you have dedicated centers for pediatric oncology, if this would help us to improve instead of having silos of pediatric patients being treated in multiple places where they still do not have all the facilities that they require? Do you think that this would help us? Thank you.
Thank you, sir, for allowing me to talk. My question is to Dr. Oteni. They are comparing this regimen with gemcitabine. Couldn't they have used the standard FOLFIRINOX and compare it at head and have a head-to-head instead of just... you can't hear me? You can't hear me? Can you hear me now? Okay. So I said FOLFIRINOX is usually used for pancreatic adenocarcinomas, right? And they're just comparing with gemcitabine. Wouldn't they have done because they are just changing to NAB irinotecan instead of irinotecan, wouldn't they just have done a head-to-head and see maybe they will have a better outcome and better really comparison? What do you think?
Thank you for the questions. I reserve my comment until the two people have responded. Dr. Joseph, over to you.
Thank you, Prof. And thank you, yes, they're excellent questions. So the first thing you were asking is that why is pediatric leukemia survival low in low-income countries? So I started making a list and I ran out of space. Diagnosis, cytogenetics, transfusions, infection control, access to medicines, bone marrow transplant, family support, affordability of care, geographic distance, delayed referral. I can go on. And so this leads to the answer to my second question. To say dedicated centers is the only way to improve survival, especially for LMICs. It doesn't make sense to try to set up cytogenetics in 15 centers. You don't even have the human resource. You don't even have the experts that are going to work in the 15 centers. It makes more sense to concentrate expertise in a few places. Now, Nigeria is huge, landmass-wise. So if we have one center in the north, the south, the east that can treat pediatrics, there will be children for whom that is still thousands of kilometers. Therefore, we must provide housing. We have to provide financial support. If you look at the St. Jude model, it tells you no child who gets treated at St. Jude ever gets a bill. But they've still got families who take their children and go back home, because those families have other children who they've left behind at home. They've got other bills to pay at home. And while you're sitting there with your child, you can't work. You are losing income. And that is more true for us than ever. Not only are they paying for treatment out of pocket, they are making no money because they cannot work. So even after we set up these dedicated centers that can do bone marrow transplants and can do cytogenetics and all of that, if we don't support the family, we're still not going to cure the children.
We'll make additional comments later.
All right, thank you, Prof. Professor Bello's question is talking about the choice of their regimens that they compared. Well, I am talking about a study that I wasn't part of, but I do know that when you are doing a study like this, you would want to use the best first line that is available now to compare it with what you want to go over and beyond. And I was under the impression that the combination of gemcitabine and Abraxane, that's nano-paclitaxel, seems to have surpassed FOLFIRINOX as a regimen for treatment of pancreatic cancer. You are the ones that designed, what do you call it, guidelines, but I was under that impression that before this study, the accepted combination beyond FOLFIRINOX is Abraxane, gemcitabine. So they were trying to go a little bit higher than what is the generally accepted code. But you might enlighten us a little bit better. Thank you.
You want to say anything? Okay. Yeah. So, yes. You have a point of the NCN guidelines. You have a point. This is a study that has been designed by those people. Yes, and we're just taking up some points. At this point in time, you cannot change methodology. You cannot change criteria. But the lesson is that there are more options. For the pancreatic tumor, 3 months addition in survivor, median survivor, is something significant. So if you don't have survivor before, these are options. But we know that we have the guideline for sub-Saharan Africa that residents must be conversant with and the consultants. But where MDT, using medical legal instrument of MDT, you think otherwise, there are some other studies to improve. Are you getting me? Your survivor. Pediatrics, we all know that if there's anywhere you will encourage multidisciplinary in cancer care, now pediatrics should be number one. 1% of cancers are pediatrics, so minute, but so significant. So the point that Dr. Ella Nwachukwu says, by having one big center located somewhere, will help a lot, but the confounding factors are also still there. I was fortunate to give a lecture on the pediatric on psychological implications, and you see, when a child falls sick, the other children suffer, the parents also suffer. So you managing a cancer baby is beyond just treating that baby. You need to understand the stress the father, the mother, they are going through. You need to understand the neglect the other children are likely to go through. You need to understand the psychological emotions attached to a baby being sick. You need to understand the guilt or even affect the relationship between husband and wife. Because the husband and wife, they don't have time for themselves when the child is sick. All these things are confounding factors. So even in addition to Dr. Ella's proposal, which I agree, maybe we should fight, where is Dr. Uche? Let's think about one comprehensive pediatric cancer center with the surgeons the pediatric cardiologists, pediatric infectious experts, pediatric surgeons, the pharmacists, everybody, and pediatric radiation oncology. Let's think of that. In addition, consider all these confounding factors and see whether we can improve survival. I hope I have done justice to the topic and to the discussion. Thank you very much. Thank you. Any photograph? I saw everybody snapping. I want to show my tummy also. Where is the photographer now? Come, Biko.
Okay, so we're slowly coming to the end of today's program. So we'll take the next session. It will be chaired by Dr. B. Olutunde.
Thank you very much. Good evening, everybody, and thank you for holding on. It's my pleasure to chair this segment that is for the MEC presentation, and to do justice to optimizing treatment in regional and metastatic squamous cell carcinoma of the head and neck, clinical cases with best practice sharing and management of anti-EGFR side effects. We're going to have Dr. Mohammed Suhail Anwar. He's from King Faisal Specialist Hospital Research Center in Riyadh. Please put your hands together. Warm your hands up together for him. He's been waiting for quite a while, and so we have to appreciate him very much. Thank you very much, sir. We're ready to listen to your beautiful lecture.
Good afternoon, everybody. I would like to thank the President and the organizing committee to give me the opportunity to present here today. I would also like to extend my thanks to Merck for facilitating this invitation. Right, these are my disclosures. So I would like to remind all of you about the abysmal prognosis head and neck cancer has. As you're all aware that over the span of 30 to 40 years, different treatment strategies have been used for treating recurrent and metastatic squamous cell carcinoma of the head and neck. And you can see that single drugs, combinations of 2, 3, or 4 drugs did not make much difference in terms of improving median overall survival. And that remained at best at about 8 months or so, until we have the addition of EGFR inhibitor in the form of cetuximab, which pushed the median overall survival for the first time in double figures. You would all remember this trial, EXTREME trial, which was a phase 3 trial on patients with recurrent or metastatic squamous cell carcinoma of the head and neck. Patients were randomized to either chemotherapy with cisplatin and 5-FU or the experimental arm with the addition of cetuximab in addition to chemotherapy until progression. And that trial very clearly showed a significant improvement in overall survival to a double figure of 10 months. You can see that there was significant improvement in progression-free survival of 2.5 months almost. The next question that came forward was whether we could do without 5-FU. As you're all aware that arranging 5-FU infusions for these patients is a nightmare, and a lot of the time patients are traveling from very distant places. In addition, the toxicity of 5-FU infusions is quite significant. So that gave the idea to replacing 5-FU by taxane. Here in this trial, TIP-EXTREME study, 5-FU was replaced by docetaxel. So patients here were randomized to either 4 cycles of chemotherapy with cisplatin 5-FU, cisplatin 5-FU along with cetuximab, which was the EXTREME study arm, and cisplatin, docetaxel, and cetuximab, which was the experimental arm in this study. Now, this study obviously showed a very significant overall survival for about 14 months, above 14 months. But for some reason, patients in the control arm also did very well. And they achieved an overall survival of around 13.4 months in the median terms. Therefore, the study was considered to be negative. However, one must appreciate the fact that the overall survival was seen to be 14.5 months for the first time in this history of head and neck metastatic cancer. The good thing about TIP-X was that the side effects were significantly fewer compared to EXTREME study. When we look at the other combinations of platinum and cetuximab along with taxane, we see a very similar trend of significant overall survivals ranging from 10 months to almost 18.8 months. Similarly, objective response rates with the addition of cetuximab to platinum and taxane in different small randomized controlled trials also shows a very significant objective response rate, again ranging from 40% to almost 63%. Now, the era of immunotherapy obviously started in about 2013, 2014, and head and neck cancer was one of those to catch up. And therefore, this trial, KEYNOTE-048, was planned, which was to use pembrolizumab as the immune check inhibitor in the first-line treatment of head and neck cancer. Patients were randomized to either pembrolizumab single agent or a combination of pembro with platinum and 5-FU, and the active comparator was used as same as in the extreme study because that had become the standard by that time. And this study was stratified according to the combined positive score of PDL-1, and you can see here that patients who received pembro as single agent versus chemo, and if they had a CPS of equal to or more than 20, they had significant improvement in median overall survival to 14.8 months compared to 10.7 months. Those patients who had a combined positive score of equal to or more than 1, they also benefited from pembro compared to chemotherapy, although the benefit wasn't as significant as seen in the population with CPS of equal to and more than 20. There are other interesting facts about the pembrolizumab monotherapy. As you can see here, that the PFS curves clearly cross. So in the first few months of treatment, more patients were responding to a regime that contains cetuximab compared to immunotherapy. However, after about 7 months, the graphs crossed over, and patients who received immune check inhibitor pembrolizumab, they started to do better. So it seems that as if immunotherapy selects out patients who are going to benefit from this approach. Obviously, other patients would be at disadvantage if they were not going to benefit from immunotherapy. So you have to keep that in mind when selecting patients for different treatments. The other fact was noticed in the KEYNOTE-048 was that the objective response rates with single-agent pembrolizumab were lower, even in the population with CPS of equal to or more than 20. It was only 23% compared to 36% in the extreme arm containing cetuximab. If the CPS was equal to or more than 1, the objective response rate fell to about 19%. And the progressive disease was also seen more commonly with patients receiving pembrolizumab as single agent compared to those who were receiving chemotherapy in combination with cetuximab. Now, why is that important? We are all aware that the burden of symptoms increases with the tumor size. So if you are able to achieve tumor shrinkage very quickly, you may be able to reduce symptoms for the patient and improve their quality of life. Coming back to the KN-048 study, we can see that if pembro was given in combination with chemotherapy, then those patients did better compared to those who received pembro as single agent. Here you can see graphs for patients whose combined positive score was equal to or more than 1. The benefit was there. However, that benefit was more pronounced in the population with CPS of equal to and more than 20, which obviously is not a surprise. Moving on to the second-line treatment, phase 3 checkmate study, checkmate 141, looked at patients with recurrent and metastatic squamous cell carcinoma of the head and neck who had progressed on previous first-line treatment. And they were randomized to receive either a single-agent nivolumab at 3 milligram per kg IV Q2 weekly. And this group was compared with the patients who received treatment of investigator's choice. And these treatments included run-of-the-mill methotrexate 40 milligram per meter square weekly, or docetaxel, or cetuximab. And the primary endpoint was overall survival, although other endpoints included PFS, objective response rate, safety, etc. And you can see here that for the first time, there was a very significant improvement in overall survival at 18 months and 24 months, which continued up to 30 months with second-line single-agent nivolumab. This benefit was seen in patients regardless of expression of PD-L1. So patients who had low expression of PD-L1, even they responded almost as well as those who were expressors of PD-L. Another study in the second-line treatment of head and neck squamous cell carcinoma is Keynote 040 study, which looked at the prospects of pembrolizumab as single agent in the second line. Again, patients with squamous cell carcinoma of the head and neck who had progressed on first-line treatment, they were randomized to either receive single-agent pembrolizumab at 200 milligram IVQ 3 weekly for 2 years, or they were given the standard of care treatment, which consisted of either methotrexate, docetaxel, or cetuximab. Here again, you can see patients who were CPS equal to or more than 1, or those who had tumor proportion score of equal to or more than 50. They were the ones who benefited. So if you remember when I talked about the checkmate 141 of nivolumab, all patients benefited in the second line, whether they were expressors of PD-L1 or not. But in this study, patients who were CPS equal to or more than 1 and TPS equal to or more than 50% only, they had a significant improvement in their overall survivals. Somebody had the sort of idea of looking at the PFS2, which is the progression-free survival 2, that is after second-line treatment. And they looked at the time from randomization to objective tumor progression on next line of therapy or death from any cause. What you can see here is that in this group of patients, those who had received immune check inhibitors in the first line, about 13 to 19% of them actually were able to receive EGFR inhibitors as second line. Similarly, those patients who had received EGFR receptor in the first line, only about 16% of them received immune check inhibitors in the second line, which is obviously very suboptimal. But in spite of that fact, the PFS2 was actually not very different in the pembrolizumab, in the group who received pembrolizumab compared to extreme when they received second-line treatments. The majority of the patients who managed to receive second-line treatment after progression of first-line treatment in TIP extreme, which is very encouraging. That means that patients who receive TIP extreme in the first line, majority of them would be fit enough to have second-line treatment. And what was very interesting was that, what was very interesting was that patients who received cetuximab and chemotherapy in the first line, when they received immune check inhibitors in the second line, they had an unprecedented overall survival benefit. As you can see here, that the overall median overall survival from randomization ranged between 19.4 and 21.9 months, which is quite significant for head and neck cancer patients. We're also aware from the basic cancer biology that some chemotherapies can mechanistically increase antigen presentation and reduce expression of PD-L2, leading to increased T-cell activation, and some other chemotherapies increase the cytotoxic effects of CTLs. And yet, there are well-known chemotherapies that have different effects on immune system. So commonly used chemotherapy agents in head and neck cancer like taxanes, platinums, and 5-FU, they have been shown to decrease myeloid-derived suppressor cells, which can also enhance anti-tumor immunity. Therefore, it makes sense to consider a combination of chemotherapy and immunotherapy to, on one hand, reduce the tumor burden, but also to manipulate its ability to modulate immune system for better responses. There are some concerns about use of immunotherapy in patients who require antibiotics just before their immunotherapy treatment or around the time they are having immunotherapy treatment. And this is one of those studies in metastatic urothelial carcinoma. However, I think it probably isn't very relevant, as we know that patients, if they are requiring antibiotics, they probably are poor prognosis group, and also they are suffering from infections. So there may be other reasons to account for poor prognosis for these patients on immunotherapy. So what are our treatment options after immune check inhibitors, platinum, and 5-FU? So we can look at the European Head and Neck Society ESMO-ASTRO guidelines, which recommend use of extreme-like chemotherapy. Similarly, TIPEX regime can also be considered as a treatment alternative to extreme for patients, especially those who have DPD deficiency. Also, a retrospective analysis from French sites has shown an objective response rate of 30%, median progression-free survival of 3.6 months, and a median overall survival of 7.8 months with salvage chemotherapy for patients who progressed on immune checkpoint inhibitors. This is some of the data from Keynote 048 once again, and it basically showed that the benefit of immune check inhibitor pembrolizumab containing regimen appeared to have been driven by the group of patients who had CPS of equal to or more than 20. So when we are selecting our patients for immunotherapy or immunochemotherapy in the first line, we need to be aware of not only their CPS score, but also other factors which I just mentioned. These are some of the retrospective studies showing promising outcome for cetuximab-based chemotherapy approach following progression on immune check inhibitor therapy in recurrent metastatic squamous cell carcinoma of the head and neck. And you can appreciate here that the objective response rates, they vary from 22.2 to about 63%. Similarly, median overall survival goes up to about 22.8 months in some of these studies, which is obviously very encouraging. So this is the retrospective study in 7 French university hospitals investigating the efficacy of taxane, cetuximab, and platinum in patients with recurrent metastatic squamous cell carcinoma of the head and neck who had failed immune check inhibitors in the first-line palliative setting. And again, you can see here the objective response rate reaching 63%, which is quite unprecedented. Similarly, median overall survival of 9.7 months in the second line, and median progression-free survival of 5 months. Quite staggering. There's also retrospective evidence suggesting that salvage chemotherapy could be a viable treatment option following progression on immune check inhibitor therapy. So we can look at these, another retrospective study. Again, patients who had received immune check inhibitors in the first line for their recurrent or metastatic squamous cell carcinoma of the head and neck. They received cetuximab-based chemotherapy, and you can see here again that the objective response rates are very high, 56.5%, and disease control rate of 78%, with median overall survival of about 12 months and a median PFS of 6 months. So what sort of inferences can we draw from the data I have presented today? So we can see that the first-line chemotherapy is important for recurrent metastatic HNSCC patients with unknown PD-L1 status. Even with strongly positive PD-L1, immunotherapy selects out patients who would have durable response while probably disadvantaging those who have low PD-L1. Majority of patients receiving immunotherapy first line miss out on the benefits of EGFR inhibition in combination with chemotherapy. We also know that the toxicity of immunotherapy such as pembro and chemo is comparable to toxicity of EGFR inhibitors in combination with chemotherapy. There is also evidence of increased immunogenicity of head and neck squamous cell carcinoma following chemotherapy, which can be exploited with treatment with immune check inhibitors in the second line. We know that there are 2 randomized trials confirming efficacy of immunotherapy in the second line, which we don't have for many other treatments. And the evidence is there in certain cancers suggesting that patients requiring antibiotics prior to or soon after starting immunotherapy do badly. Also, we have to keep in mind that disease burden dictates symptomatology and quality of life. So it should be considered in deciding on anti-cancer treatment therapy for locally recurrent or metastatic HNSCC. These are the NCCN guidelines, and I've deliberately picked up slightly older ones because the point I wanted to make was that they haven't really changed much in the last 2 years. So although nowadays they give these preferred regimens, but also other recommended regimens, they actually contain almost everything. So you can choose whatever for your patients depending on their symptomatology, their disease burden, other logistics, patients' performance status, where patients are coming from, their allergies, DPD status, etc. So I would like to conclude in the end that for locally advanced metastatic HNSCC patients with CPS of equal to and more than 20, there is clear evidence for pembrolizumab plus minus chemotherapy. So you can use it either single agent or with chemotherapy. If the combined positive score is equal to or more than 1, there is enough evidence to consider pembrolizumab plus minus chemotherapy again. If CPS is equal to or less than 1, there is enough evidence for pembrolizumab plus chemotherapy. Obviously, you can't use single agent pembro for patients whose combined positive score is equal to or less than 1. If the combined positive score is not known or is less than 1, you may consider chemotherapy with EGFR inhibitor or pembrolizumab with chemotherapy. So you have got 2 options there. And for second line treatment, consider cetuximab in combination with chemo if patients have received immune check inhibitors in the first line and the vice versa. So obviously if they've received EGFR inhibitors in the first line, you can go with the immune check inhibitors in the second line. Thank you very much. That's the end of my first presentation. I've got another one for you.
Thank you very much, Prof, for your exciting presentation. Prof has 2 presentations. I was thinking we could take 1 or 2 questions right now so that we can then go on to the second presentation. I see 2 hands up. I will be taking those 2 questions together and then you'll respond. Thank you very much. 3 hands, please. Okay. Thank you, sir.
Thank you, Professor Anwar, for the brilliant presentation and shedding more light on immunotherapies in head and neck cancers. One will want to ask, really in a place like in our environment where the scoring is very difficult and indeed PD-L1 testing, and because of the immunogenicity of the disease, will you agree that empirically one could consider using pembro and chemotherapy in patients that are already pre-treated? Thank you.
Sorry, did you say patients who've already been treated?
Yes, patients that are metastatic and they are already pre-treated with recurrence and metastasis. Will you consider, empirically using pembro, or we need to do the PDL testing?
Yes.
That's the question.
Okay. No, a very good question, really. I mean, even in bigger centers, sometimes PD-L1 testing can take some time. Although in our center we have managed to get a system where we usually get it within 2 weeks. However, I agree with you. Patients, if they do not have PD-L1 testing done, then the first thing which is important is they have to have chemotherapy. You can't just give them immunotherapy or EGFR inhibitors on their own. So you're right. They will have to have chemotherapy, and then it's up to you. If you want to give them immunotherapy, fine. If you want to give them EGFR inhibitors, that's fine. NCRN guidelines obviously say preferred treatment is immunotherapy, but you can use either depending on, as I said, different factors.
Thank you, Prof. Dr. Lolade.
Thank you very much for your presentation. I just wanted to initially find out, I saw in one of your slides that if they're pre-treated, you can still have them on the other arm. So in your own practice, which arm comes first from what you see? Is it the pembro arm or the EGFR arm? That's the first question. Then the second question is, I also observed that there's, of the 3 options of the chemotherapy, there's the methotrexate, and there's the taxane, and before you come to the platinum. So I wanted to find out that the outcomes of those 3, are they equivocal, or is one ahead of the other? Because you mentioned that the standard of care was 1, 2, or 3 because of the economics and the financial involvements of those 3 of them. Thank you.
So the first question, obviously, if you, because Tipex is off-label, so using docetaxel, cisplatin, and EGFR inhibitor is off-label at the moment, but it is a recommended treatment. However, the first-line treatment should be an immunotherapy such as pembrolizumab with chemotherapy. That is the preferred treatment. But if you have reasons not to give pembrolizumab, for example, if you don't test in this country, then you have the option to use whatever you like. So you can either use pembrolizumab with chemotherapy, or you can use EGFR inhibitor with chemotherapy. Both have their plus and minus points. For example, with pembrolizumab, the issue is that you will have to use cisplatin and 5-FU. So patients will have to have an infuser port, and then they will have to have a continuous chemotherapy for 5 days. So that against Tipex regime, where you're using 1-day chemotherapy, however, they have to come every week for cetuximab. So they both have their plus and minuses. In my practice, I have used both of them, and I don't want to influence you, but to be honest with you, my experience is that cetuximab containing regime there is a higher response rate. So I see more patients responding to that treatment compared to immunotherapy and chemotherapy in the first line. Now coming to your second question, the preferred regime is actually taxane and cetuximab in the second line. If patients have received immune check inhibitors in the first line, it is important to have a taxane with cetuximab plus minus platinum. because most of these patients would have received platinum in the first line anyway. So they're probably to a degree platinum resistant. So you can use taxane and cetuximab, but if you want to use the best regime, that will be a combination of three, which is cetuximab, platinum, and paclitaxel or docetaxel. I hope it answers your question.
Thank you, Prof, for a beautiful presentation. From the presentation, we could see clearly that including pembrolizumab to chemotherapy for the series of studies carried out will, of course, give us a better outcome. Consider this environment. Pembrolizumab Keytruda is quite pricey. It is in the order of between 4 million to 6 million in Naira. And because of the current exchange rate, probably it could be a lot more. And of course, running the PDL and PDL1 test too could be a little bit challenging. So we are left with, traditionally we will use TPF regimen for our induction chemotherapy. And of course, we do our chemoradiation with platinum-based. And so my question has been partly answered, but I would still love to have some more, a point added to that. That in the absence of the aforementioned, considering our setting here, so what would be your recommendation? That's one. Then secondly, did the study consider patients that progress after chemoradiation still using the same regimen in the studies?
Okay. So your first, thank you very much for your questions. So the first question, basically, I mean, to be honest with you, I don't know the price of cetuximab and pembrolizumab. But if you think, because the problem with cetuximab, you will have to give it weekly during the chemotherapy part. But the good thing is that if you are using TIPEX regime, you will only be giving 4 cycles of chemotherapy. But if you are using pembro with chemotherapy, you'll be using 6 cycles of chemotherapy. So that's one advantage of using EGFR inhibitor. The second advantage of EGFR inhibitor is you don't need to worry about the PD-L1 status. Having said that, you can use pembro in combination with chemo for that group of patients as well. So I think at the end of the day, you will have to make that decision. I think you are in a unique situation that you have the choice. You will have to consider each patient, first of all, what they can afford, and then you can make decisions. You can use either. You can give them pembro plus chemo, or you can use cetuximab with chemotherapy. I think they are, if you look at them separately, both of them have very similar overall survival. 14.5 months, you see, for both groups of patients. Although we shouldn't make sort of comparison between two trials, but if you look at the TIPEX, it shows that the overall survival with TIPEX regime is 14.5 months. And this is very similar to what we see in the KN048 study with pembrolizumab and chemotherapy.
Thank you very much, Prof, for the thought-provoking lecture, giving us insight into clinical practice, and answering quite many questions as to what we should do when we're confronted with this situation. Thank you so much. We'll quickly move on to your second presentation, which I hope will not be too long. We'll be talking about best practice sharing and management of anti-EGFR side effects. Thank you.
Thank you. I was going to take my own back with the second presentation because you made me wait so long to present it. So I was going to make it 1 hour long, But anyway, I'll have to...
We plead, and we're deeply sorry for the time wasting.
No, that's
Please
okay.
go ahead, Prof. Thank you.
That's fine. So what I'll do is I'll try to skip through some of the slides, and the others I will whiz through, so hopefully we will manage to finish it.
Thank you
Again, these are my disclosures. I think there's no better way than starting with a case presentation, really. I think that this is very close to everyone's heart. We're all clinicians, and when we have a case, then we are a bit more interested. So if I start with case 1, this is a 55-year-old gentleman with inferior alveolar squamous cell carcinoma back in 2020. He had surgery and adjuvant chemoradiotherapy with high-dose cisplatin. And this patient came back with a newly developed left axillary lymphadenopathy. There was no other disease anywhere else. You can see on the PET-CT scan large mass in the axilla. So this is the CT scan again. It's very clear, very large mass in the axilla. So we then hummed and hawed what to do, and eventually the tumor board decided that as this is the only site of disease, we should go for surgery. So patient had en-bloc dissection, margins were involved, and we planned to give him some adjuvant radiotherapy to consolidate treatment. Sadly, within a few weeks, patient had further recurrence. As you can see on the CT scan, lots of masses in the axilla, and there were lots of subcutaneous metastasis in the same area, along with lung nodules. So we went through the usual ritual to go through the treatment options, which you all do, whether you mention them or not, but they all go through your head. And we decided that this patient should be treated with Tipex because we did not have CPS available. So we started this patient first cycle of Tipex, which is cisplatin, docetaxel, and cetuximab in May 2021. Patient had a very good response even after the first cycle, but he ended up having a neutropenic infection and hospital admission. When I saw him in clinic for the second cycle, he had toxicity in the form of oral mucositis and papillopustular rash on the face, arms, and chest. We treated it symptomatically, which I will go through in a minute with you. But we went ahead with the second cycle with 20% dose reduction, and patient continued to respond. Cycle 3 was also given with further 20% dose reduction because he was still struggling. However, he didn't want to give up because he was responding so well. And after 3 cycles of chemotherapy, he had near complete response, as you would see here in this scan. There's hardly any disease left in the axilla or in the lungs. And that's his PET-CT scan after 3 cycles. Sorry, I go back. This is a more recent PET-CT scan. But since then, this patient has been in remission for the last 2 years. He's on 2 weekly cetuximab, and we are managing his rash. This is case number 2, another 61-year-old gentleman with vocal cord cancer. Again, very similar history of recurrence twice. And then he developed, if I go to next slide first. So you can see here quite extensive disease in the neck area, here on the PET-CT scan and the adjacent lymph gland area. And he was fistulation there in that area. So I'll go back now. So we knew that there were no options in terms of surgery or radiotherapy for this patient. And again, this patient did not have PD-L1 testing done. And we were in a bit of a rush to start treatment. Patient lived locally, so I was happy to start him on Tipex. He responded very well, but he developed some papillopustular rash on the face, for which we used treatment, which I will explain in a minute. He also had some hypercalcemia, and I think that was related to his primary disease, which we treated with zoledronic acid. So this is his scan before we started treatment. This is his PET-CT scan. And then after 4 treatments, you can see all the disease melted away. So he had, again, complete response to this treatment. So for his rash, we used doxycycline 100 milligram orally BD, sorry, there's a mistake here, it should be BD, for 6 weeks, and we also use topical 1% hydrocortisone cream. Now coming to the side effects of EGFR inhibitors, mucositis I put first because this is the one you see when patients are on radiotherapy. We don't usually see it very much with cetuximab on its own. It's usually when cetuximab is being used with radiotherapy or with chemotherapy, other chemotherapy, such as in the TIPEX regime, we had docetaxel and cisplatin. So what are the risk factors for mucositis? It's obviously poor oral hygiene, periodontal disease, persistent alcohol or tobacco use. It can lead to xerostomia and hypersalivation. And what are the treatment factors which increase the risk of mucositis? Obviously radiotherapy, the total dose of it, the fractionation, previous radiation, and also chemotherapy. These are the different grading criteria. I'm not going to go and dwell on these. You're probably all aware of these. So what do we do for mucositis? We have pre-treatment recommendations to reduce the risk, such as oral hygiene education. We advise patients to use soft toothbrush, floss, interproximal brush, and fluoridated toothpaste. Also, we look after the dental care, control of pre-existing periodontal dental disease, professional dental cleaning, and we always try to have an integrated approach by multidisciplinary oral health care team. But these patients must be told to stop smoking and alcohol, especially during treatment. What are the on-treatment recommendations? So again, for oral hygiene evaluation, we tell patients to concentrate on oral care using soft toothbrush and non-irritant mouthwash with no alcohol and without intense flavor. And they should do it regularly. Cleaning of oral prosthesis with antimicrobial solutions and avoid wearing them at night. The assessment of the mucositis should really be carried out on weekly basis, and patients should be advised to communicate with the health professionals if symptoms get worse. There are set NCCN recommendations for the management of mucositis. So it all depends on whether mucositis is associated with xerostomia, pain, or infection. So if patients have xerostomia and it's mild degree, then we give them normal saline or soda bicarb. But if it's moderate degree, then silogogues are used. For patients who have pain, we use topical anesthetics in the first place, containing lidocaine, benzocaine, etc. But obviously, if it becomes moderate to severe, then we have to use systemic analgesics, including hydrocodone, morphine, oxycodone, etc. If patients have infection in the mucositis, then we can use antibiotics, antifungal, antiviral. We frequently see dysphagia in patients who are having especially chemoradiotherapy or bioradiotherapy, and some of the patients who are likely to get dysphagia are patients with large tumors, node-positive disease, and those who have non-glottic cancers. And the treatment factors which can affect dysphagia are obviously accelerated radiotherapy, which causes more symptoms. Now, according to the Bonner study, where they used cetuximab in addition to radiotherapy, it did not show an increase in the level of mucositis or dysphagia. So what are the acute and long-term management strategies to reduce the burden of mucositis and dysphagia? So in the acute setting, vigilant monitoring is required. We limit treatment intensifications, topical therapies, which I mentioned earlier, thorough oral care, nutritional support, analgesia, etc. And in the long-term management strategies, we include nutritional management such as dietary modifications, feeding tubes, etc., functional rehabilitation like swallowing therapy, and invasive treatments including esophageal dilatation. And there are obviously conservative treatments such as nitrates, calcium channel blockers, anticholinergics, etc. So now we look at the cutaneous side effects of the anti-EGFR medications. Acne-like rash, which is the papillopustular rash, which I mentioned to you in my 2 patients, is very common. It's seen about 60 to 80% of the patients. And there is some evidence to suggest that the appearance of this rash may actually give you some indication of treatment working. So we are not really too much worried about this rash. Dry skin is seen in up to 1/3 of patients, paronychia and cracks in a small proportion of patients, and rarely we see changes in hair texture. So this is the time course of anti-EGFR related skin reactions. Most of the skin reaction is seen within the first 3 weeks of treatment, and they usually resolve without sequel following cessation of treatment if the recommended adjustments in dose regimen are carried out. So what are the preventative measures? Lots of them. So prophylactic measures may allow for better control of skin reactions. And prophylactic use of oral tetracyclines up to 6 to 8 weeks course with topical application of 1% hydrocortisone is very, very effective. And I use it a lot. Sometimes I use minocycline at 100 milligram once a day. Sometimes I use doxycycline 100 milligram twice a day. It all depends what pharmacy has. Because when you write minocycline, they don't have minocycline. When you prescribe doxycycline, they run out of doxycycline. So you need to be aware of alternatives. And there is obviously advice for patients to cleanse gently with lukewarm water and pH neutral bath and shower oils. They should use perfume and alcohol-free moisturizing creams and lotions, and they should avoid tight shoes, use sunscreens, and minimize shaving where possible. Rash seen on the face, you know the different degrees of rash. I'm not going to dwell on that. But how do you manage it? Treatment options include impact on use of Erbitex. And there are clinical practice guidelines to guide you all. If the rash is grade 1 or 2, you can use topical corticosteroids, or you can use topical clindamycin. But if it is very moderate to severe, then you usually have to resort to systemic treatment with doxycycline 100 milligram BD or minocycline 100 milligram daily, as I mentioned earlier. In very few and rare cases, you have to resort to isoretinoin at low doses like 20 to 30 milligram per day. Dryness of the skin, again, it is seen mostly in elderly subjects, and there are different degrees depending on the involvement of the body. Treatment options, again, we tell them to use fragrance-free occlusive emollient creams containing urea or colloidal oatmeal or petroleum-based creams. You can use topical corticosteroids for severe xerosis. You can use exfoliants containing ammonium lactate, for example, or lactic acid creams for scaly areas. But usually we don't use retinoic acid because they themselves can cause dryness of the skin. Cracks and fissures can be painful, and they typically affect fingertips, knuckles, and toes. Again, we tell patients to use protective footwear and also cover fingertips by applying hydrocolloid dressings, which reduces the friction and aids in healing. You can use propylene glycol 50% solution and thick moisturizers. You can also use liquid cyanoacrylate glue, which can seal cracks and prevent worsening or infection, along with 10% salicylic acid ointment. Paronychia, we usually advise patients to wear comfortable shoes and trim their nails and wear gloves while cleaning to minimize trauma. Topical corticosteroids and anti-inflammatory medicines can be used, and tetracycline may decrease perifungal inflammation. Antiseptic soaks such as diluted bleach or vinegar is also used to prevent superinfection, and rarely we have to resort to electrocautery or silver nitrate. Pruritus is uncommon, but obviously usually you use either, if it's a small area that is affected, you can use topical steroids or topical menthol, bromoxine or doxypen, and in severe cases you have to resort to gabapentin or pregabalin. So what do you do in terms of the doses of treatment, both radiation treatment and cetuximab treatment if someone develops these skin reactions? So this is just a chart to tell you that if patients have cutaneous reaction which is less than or equal to grade 2, usually you do just continue with the treatment with both radiation and with cetuximab. If patient is only on cetuximab, you just continue and you just monitor and do all those things which I just explained earlier. If they have severe cutaneous reactions of grade 3 and more, you interrupt treatment and adapt care. After the first episode, once there is an improvement to grade 2 or less, you restart treatment at the normal dose. However, if it happens again, you interrupt treatment, and after improvement to grade 2 or less, you start again. However, you do dose reduction at 200 milligram per meter square weekly of cetuximab. And after the third episode, you reduce the dose to 150 milligram per meter square weekly, cumulative. But if it happens fourth time, then you discontinue Erbitux treatment, really. Digestive toxicity, I haven't seen much really. I mean, nausea, vomiting, you all know how to manage, so I think I'll skip this one. Infusional reactions are seen with Erbitux. They can be mild to moderate in the form of fever, chills, dizziness, but they can be quite severe, requiring immediate and permanent discontinuation of Erbitux and may necessitate emergency treatment. They can be in the form of severe breathing difficulties, hives, fainting, and chest pain. I have to admit that in my practice, I've treated lots of patients with Erbitux, and only one patient developed mild to moderate allergic reaction to infusion, where we had to stop it, but we were able to give it second time at a slower rate. These are some of the considerations for Erbitux related infusion reactions. So you normally give pre-medication, which is compulsory before the first dose. You use antihistamine and corticosteroids, and then you give your cetuximab at loading dose. And for the subsequent doses, you use the same pre-medication. However, as I mentioned, I have a lot of patients who are on this treatment and they don't even require pre-medication, but this is not normally recommended. However, in cases of severe infusion-related reactions, if they happen, you should immediately and permanently discontinue Erbitux. Eye disorders, again, are very uncommon. If patient has a history of keratitis, ulcerative keratitis, or severe dry eye, Erbitux should be used with caution. And if signs of keratitis are apparent, like acute or worsening eye inflammation, lacrimation, or light sensitivity, blurred vision, eye pain, etc., then patient should be referred to an ophthalmologist immediately. If ulcerative keratitis is confirmed by the ophthalmologist, we usually recommend that you do not give cetuximab anymore. Now, radiation dermatitis can be due to radiation itself, and it could also be what we call biodermatitis, which could be due to cetuximab treatment in combination with radiation treatment. These are the different grades you're all aware of. If I just skip a couple of slides here to move directly on to the, yes, we know that the the incidence of radiation dermatitis with cetuximab radiation is little bit higher compared to just cisplatin and radiation. But the pathophysiology is very different. In radiation dermatitis, you see that the basophilic degeneration of superficial dermis and dilated blood vessels. But in bioradiation dermatitis, there is interruption of the epidermis and obviously inflammatory lymphoplasma cellular and granulocytic infiltration of subepidermal layers. So how do you differentiate? The bioradiation dermatitis happens very quickly. There's a quick onset. Within a week or two of treatment, it appears. However, radiation dermatitis is usually 3 weeks onwards, as most of you radiation oncologists are aware of this. There are different grading systems for bioradiation dermatitis, and there are discussions ongoing to sort of change this. I will leave that discussion. So how do you manage bioradiation dermatitis associated with radiotherapy and cetuximab? Well, in the past there were certain guidelines and they haven't really helped. Presently, the exact incidence of development of grade 3 to 4 bioradiation dermatitis in locally advanced squamous cell carcinoma of the head and neck is still a matter of debate. There needs to be need to identify best approach for managing these skin reactions, and the future probably lies in advanced wound care nursing teams to monitor and manage development of bioradiation dermatitis, and use of calcium alginate fibers as they are highly absorbed dressings and are able to remove the excessive exudate. That might be a good strategy. So there is a retrospective study from Bonomo, and you can see that they developed a sort of a home protocol of managing bioradiation dermatitis. And with that, compared to the traditional treatment, they managed to reduce the radiotherapy interruption, which was normally on average about 8.42 days, using the conventional way of managing bioradiation dermatitis. They managed to reduce it to less than a day. So I think some of their recommendations are that you should have a dedicated team to look after your patients who are at high risk of developing bioradiation dermatitis, and there should be set protocols to manage these patients. So this is just an example advice really for patients to aid prevention of radiation dermatitis or bioradiation dermatitis. There are things which can be done before starting treatment and assessment of the patients, and then obviously during treatment what factors. You can see the list there, and after treatment they require a management even after the radiation treatment has finished and their dermatitis is gradually settling down. So in terms of the dose adjustments for bioradiation dermatitis, the recommendation is that for grade 1 you usually don't change the dose of radiation or cetuximab, but you do maintain hygiene with mild cleanser for patients and advise them to use topical moisturizers. If they develop grade 2 dermatitis, still you should not change radiotherapy or cetuximab dose, but you increase the level of other interventions and include normal saline on non-abraded skin, occlusive wound dressings, only on crusty exudates, hydrogels, but do not use prophylactic topical antibiotics for grade 2 bioradiation dermatitis. For grade 3, again, radiotherapy dose should not be changed, but cetuximab doses should be reduced until regression to grade 2 toxicity. And the other interventions are exactly the same as for grade 2 bioradiation dermatitis. For grade 4 radiation dermatitis, you discontinue radiotherapy and verify dose and distribution, and then restart as and when appropriate. Cetuximab you should really discontinue if somebody develops grade 4 dermatitis. And you should also discuss these patients in your MDT or tumor boards to have input from the other specialist teams. I think this I have covered. I will probably skip this one. All right. Okay. So in concluding, I would say EGFR inhibitor is an important and effective treatment in the management of head and neck squamous cell carcinoma. What I have shown you is a manageable toxicity. Yes, it has some toxicity, but it is very well known, recognized, and manageable, especially in bigger centers. In smaller centers, if you have issues, you can always look at the guidelines. You should follow published consensus guidelines and Merck guidance for managing toxicity of cetuximab. Thank you very much for your patience.
I would like to thank you so much, Prof, for walking us through the side effects of cetuximab and how to handle them. Thank you. Very applicable clinically and very well delivered. Thank you so much. Do we have any questions? I'm excited. I can see hands up already. Let me see your hand up. It was really engaging. Thank you. And this is why we're having questions. Any more hands?
Thank you very much, Prof, for a very exciting lecture. I would have preferred that this lecture was given earlier in the morning so that we'll be able to assimilate it better. But this is actually a lecture that is important to our clinical practice. So while talking about mucositis, I saw somewhere you mentioned use of tetracycline or doxycycline for 6 to 8 weeks. And I was wondering that prolonged usage of antibiotic.
Sorry, that wasn't for mucositis. That was mainly for maculopapular rash, the pustular rash.
Okay, okay. And it's oral?
Yes, it's oral. So you either use minocycline 100 milligram once a day, or you use doxycycline 100 milligram BD obviously twice a day for 6 to 8 weeks. And if need be, you can repeat those 6 to 8 week courses.
Okay. Because I was wondering, prolonged usage, won't it predispose to colitis, enterocolitis, that prolonged usage?
So the 6 to 8 weeks is a recommended time period. And if you give patients rest after that, and few weeks later, if they require it again, you can repeat the course. But obviously, you won't keep them on it forever. So you can give courses and stop them.
Okay. And then for the cracks and fissure, the hand and foot syndrome, I saw that you specifically mentioned thick topical cream, moisturizer, sorry, a thick moisturizer. What we have in the country commonly is we just, personally, I ask patients to get moisturizing cream because we don't have just pure moisturizer that may not have other components in it.
That's fine. You just have to do your best. So whatever is available, but the most important thing is that you have to tell patients to look after their hands and feet. Obviously, they need to wash with lukewarm water, but not excessive washing. Washing maybe twice a day, and they trim their nails, and they wear gloves when they are doing rubbing or any other jobs. So those other interventions also play a part.
Thank you very much.
Once again, thank you, Prof. For lack of time, I'm not going to ask too many questions, even though I have quite a number. Considering so many side effects of Erbitux, at some point I was wondering if the potential risk, so to say, does not outweigh the benefits. Well, but my question is, in your own practice, in your own setting, what would be the most encountered side effects? Thank you.
Thank you very much. You can ask me more questions later on if you want to. That's not a problem. So in my personal practice, I've noticed that the most common one is this papulopustular rash. The others are actually not very common. Mucositis we see sometimes if you are giving chemotherapy, which is very intense, or patients who are having radiation therapy. Apart from that, the other side effects are not very common actually. So I don't see them as much. I mean, I've been treating patients for the last 4 years with cetuximab, and I've got lots of patients on treatment. The other issue is that once they are on the treatment and they respond so well, they don't want to stop it. Even if you tell them, oh, stop it for 2 weeks or so, they don't want to because they've seen those big lumps shrinking down to almost nothing. So it is a bit of a challenge to try to convince patients to stop treatment sometimes. But yeah, most of the toxicity is manageable. And although I went through a lot of side effects and toxicity, but actually not everybody is going to get that toxicity. The most common, as I showed you, 70 to 80% will get some sort of rash, especially on the face.
All right, do we have any more questions? Oh, yes, sir. Dr. Igbinoba has a question.
Thank you very much, Prof, for a beautiful lecture, well delivered. The experience I have with cetuximab is that when I keep patients on this drug, compliance is very poor. Patients just take the first few and say, doctor, sorry, I can't continue, as it's financially beyond them. I don't know how you manage in your center to deliver this drug to the end. That is in terms of giving it all through and the patient is compliant. Is it your government sponsored or how do you manage that? Thank you.
Thank you very much. That's a good question. So, I mean, I'm very fortunate that where I am working, finance is not a problem. So the government has, or our hospital has made it available for patients free of cost. So we don't have that issue as such. But I understand the other point you made, and that is having to come for treatment again and again. Because some of my patients come from very far off areas, and so we give, for maintenance, I use 2 weekly. I don't use weekly. Even 2 weekly, sometimes they want treatment breaks. So that's how I manage it. So instead of stopping it all together, I advise them, okay, let's have a break of 1 month or 2 months and see how things are, and then we can restart. Having said that, patients who have been on this treatment for like more than 2 years, I don't know what to do with them because basically they are in remission for 2 years and they are afraid of, and I am afraid of stopping it in case it comes back. But I'm willing to give it a go if they're not very keen to carry on. Yeah, but I mean, the issue of 2 weekly treatment, it can be expensive. That is an issue. And it can be quite demanding for patients to having to come, especially if they're coming from a long distance.
Thank you very much. I believe we're done with questions. Let's put our hands together again for Dr. Anwar from the King Faisal Specialist Hospital. We want to thank you.
Thank you very much.
For the brilliant lectures, and we also want to thank you for being gracious and waiting for us until we were able to get you on board. Thank you very much.
Thank you
Please
very
put
much.
your hands together again. Oh, I insist on a picture as well.
While the pictures are being taken, We want to really appreciate everyone that stayed till the end of today's session. There's some of us that we know that our session still remains one, or that's a side meeting. And for those of us that we're continuing tomorrow is our final day, day 3. It will be a very exciting day. Tomorrow we have abstracts to be presented. Tomorrow we have the Young Oncologists Forum. Tomorrow also the members of Arcon know that we have the annual general meeting. And tomorrow is also the annual dinner. I mean, so, so tomorrow is a full day, and it's going to be a day that is loaded with a lot of excitement. Please, let's make sure that we go to the headshots place. I've had mine done. Make sure you have those headshots. Those pictures are going to be very useful for you as you go on in your career. I mean, when they will be asking you to send pictures, either for profile picture for your department or for profile picture for a website and all that. That camera is digital camera. It's about 5,000 for about 4 pictures. So make it a point of duty to have it. It's very important. It pays, sir? It's on that side, in that exhibition stand. And it pays attention to a lot of details. It's very good. It's high definition camera in that headshots place. Let's make sure, let's not waste the opportunity, because you know how it is. If you go and have this done outside, it will take you a whole lot of, but they are capitalizing on number that we have. And most of us that were well dressed, and you know, if you want to be in your native and all that, if you want to have it done tomorrow morning, or how much? It's 5,000 naira for each individual. Do you understand? I mean, so please, I paid mine. Do you understand? For that headshot, it's very important. If the cameraman takes many views of your face so that and it's high definition, it will be very important for you. Thank you very much. Have a wonderful evening. Enjoy Enugu. Enugu is a very interesting place. Thank you. We take dollars. We take dollars. That's just about, I think that's just about, is it 5? No, we'll take $10, sir. $10, just $10. $10. Please, we are still looking for one mic. If there's one mic mistakenly in your bag, please don't go home with it. Thank you.